So good morning, everyone. I welcome you all to today's session of CIDS Delhi chapter 2022. After a sumptuous breakfast, I think it's a bit of a lazy start, but still we need to start. So today's first topic is to do with the UTI, interpretation of urine cultures. So I'd like to invite the moderators for the session, Dr. Manu Gupta, who's a senior urologist at Sir Gangaram Hospital and has a IVF clinic of his own in Delhi, and Dr. Neha. We all know Dr. Neha, multiple introductions. I don't think any more required. And I would like to ask the moderators to introduce the speaker and start the session. Speaker.
Yeah, a very good morning to all of you. And we begin the second day of our CIDS Delhi chapter with a wonderful session on a very common topic, which is urinary tract infection. And for this, we have a very eminent speaker, a very senior physician, infectious diseases specialist, Dr. Ravikant Purwal from Jaipur. And he is practicing in Manipal Hospital in Jaipur. So we begin the session on UTI.
Thank you, Dr. Neha, for the nice words. Good morning, everyone. And thank you so much for showing up on Sunday morning. And my best wishes to the entire Delhi team for creating a Delhi CIDS chapter. And let's talk about the most common infection which we see in our daily practice, which is urinary tract infection. And I must congratulate Dr. Neha to keep the theme about test interpretation, because it is very, very important to interpret investigations as a tool to the diagnosis of infection which you are ordering in your patient. So this is going to be the outline of my talk. I'll be discussing few clinical cases with all of you, and then we'll touch upon the brief overview of clinical syndromes, specifically in urinary tract infection. What are the tools available to us? Something about that, and then what are specific challenges in our setting. So to begin with, it is a first case. He's a 36-year-old male, ex-army soldier. He had traumatic quadriparesis with bowel and bladder involvement on intermittent catheterization. He was actually referred for an ID opinion saying that he has a MDRO infection, and which is not getting away by multiple antibiotics, which was used on him by his primary clinician, which was in quinolone and meropenem. And this was his culture when he came to us. You can see that it is Klebsiella pneumoniae, and which is resistant to multiple drugs. Only there is intermediate susceptibility to cholesterol. So on detailing, when we asked him, he went to his routine neuro consult about a month back, and that time he was found to have leukocytosis with the PMN of around 76%. There was pyuria, and his urine culture was ordered, which came positive. And he was started on levofloxacin for 7 days, but it didn't help. His repeat culture was also done, and which was positive. So at that time, neuro physician referred him to the physician OPD, and initially was put on nitrofurantoin for 10 days. But again, the culture was positive, which was a follow-up culture, and he was given IV antibiotic in form of meropenem. So when we asked him, he clearly denies any symptoms of lower urinary tract symptoms, fever, or any troubling symptoms. What he only tells us that after taking so much of treatment, my appetite has lost. So what is this syndrome? I think we can summarize that it's a young male with a traumatic spine injury on intermittent catheterization. He is completely asymptomatic as far as urinary syndrome is concerned, but he has pyuria and a MDR bacteriuria. So I'm sure it's self-explanatory. It is an asymptomatic bacteriuria. So are you going to treat it or not? It's a question for audience. No, great. Anybody else who differs from this opinion? Okay, so I think it's a wonderful thing. But before we go further, I think we should know what is the prevalence of asymptomatic bacteriuria. This is straight from IDSA guideline, and in the setting where actually we are discussing, in setting of traumatic spine injury, it is in the range of 25 to 70% around. And the guidelines are very clear that you should not be treating asymptomatic bacteriuria in that particular setting. By definition, asymptomatic bacteriuria clearly means there is a significant colony forming unit, which is more than 10 to power 5 in urine culture, and person has to be asymptomatic. And this definition is actually independent of presence or absence of any of these symptoms: pyuria, smelly urine, cloudy urine, very bad looking urine, which are actually subjective markers to start antibiotics for physicians. If you see, it is not uncommon to see asymptomatic bacteria in various settings, right from young healthy women to to the elderly population. As you age, actually the prevalence of asymptomatic bacteria goes up to 40%. And if there are obstructive uropathy, neuromuscular disease, bladder dysfunction, neurologic problems, the chances of asymptomatic bacteriuria goes up. And there is a significant shift in the teaching or understanding of asymptomatic bacteriuria. The traditional teaching was that you try to eliminate the asymptomatic UTI, so-called UTI, which minimizes the risk of clinically symptomatic disease. But the modern teaching is that it is not beneficial except in certain setting, which is pregnancy and before any urologic procedure, because you are going to do any intervention in that situation. And that's where the term is changed to asymptomatic bacteriuria. And there was a very nice study which was published in 2012, where they have done a study on around 670 odd non-pregnant female, where actually they were treated for first UTI episode for 1 year and then followed up for 1 year. And the follow-up cultures were done in 3, 6, and 12 months. And even if it is positive and they are asymptomatic, half were treated, half were not treated. And this were the results. The asymptomatic bacteriuria, when they tried to treat it, there was a symptomatic UTI later during the year in around 46%, while people who did not get any treatment, it was around 13%. So the conclusion was very clear that you are not going to treat asymptomatic bacteriuria. So take home masses, you are not going to try to fix it if it is not broken. Specifically, exceptions are pregnancy and any urologic procedure. Moving to the another case, it is a 51-year-old male from city who is an X-ray technician in medical college, and he develops a high-grade fever with chills since last 3 days, prominent dysuria, increased frequency. There's no pain abdomen, no systemic complaints. On the background, he was recently diagnosed to have type 2 diabetes, and about 3 months back, and he was started on dapagliflozin and metformin. And he was seen in Department of Medicine for this episode, found to have leukocytosis, numerous pus cells, there were glucosuria, and urine cultures were asked. His creatinine was around 1.2. Was started on levofloxacin and cefixime, which is a common antibiotic prescribed in office setting. But he didn't get better in further 2 days. So he followed up with the physician, and by that time this culture was there. So this is a urine culture report from a teaching medical college from a city. You can have an idea what kind of urine culture report it is. And based on this report, whatever was available to them, they changed, they kind of stopped the cefixime and changed to amikacin and doxycycline, continued levofloxacin. And the patient took it for another 3 days. And at midnight, he came to our hospital. He was definitely not looking good. He was drowsy, febrile, hypotensive. His lactate was around 3.2. His creatinine, his RBS was 240. He had left flank tenderness. Clearly, he was not doing well. So what do you think at this moment? Are we dealing with, I think these kind of questions should cross our mind when we see these patients. Are we dealing with upper or lower UTI? Is it a complicated or uncomplicated UTI? And what is immediately concerning for us at this moment? So I think looking at the case, we know that he's a diabetic and male, which makes him a ideal candidate for complicated UTI with, and definitely there are signs of severe sepsis. Probably we are dealing with acute pyelonephritis, and immediately we should rule out whether there is a emphysematous change, any obstruction is there, if there is a renal abscess or evolving abscess. So for that, you need to send appropriate cultures, immediately start earliest fluid resuscitation, as well as appropriate empiric antimicrobial initiations, and imaging has to be top on the cards. So cultures were taken. He was started on a meropenem 1 gram state. His creatinine was around 2.24. His procal was 41, and a non-contrast CT abdomen was done. And this was a CT abdomen. You can say that you can see there is a left kidney which is ballooned up, and there is a small calculus also there in the renal pelvis. He was very sick. He was moved to ICU, and meropenem was modified based on EGFR, and an urgent urology consult was done, and it was suggested to have a PCN on this particular gentleman. And this was a turbid, clearly turbid pus-like urine we got when the PCN was done on this patient. Finally, his blood and urine cultures are now available to us. So again, since the theme of the CME is interpretation, so what is the interpretation of this culture? Any inputs from the audience? Yes, sir. So meropenem is started only in this episode when he reached to us. Initially, he has received amikacin, levofloxacin, and doxycycline. Yeah. So, so my question is, can we really have any idea what kind of resistance mechanism, what kind of isolate is this, looking at this particular urine culture report? So in the want of time, if anybody wants to volunteer, I would be happy. ESBL. Okay. Yes, Neha.
Here we have it's ESBL with an extra mechanism as well, because we have piperacillin tazobactam which is resistant. But if you look at it, cefiberazone sulbactam is reported as sensitive, but we can't take it as sensitive because there is a discordance. Plus, cefepime is resistant. So that indicates that.
Yeah. So I think rightly pointed out in this particular isolate, first thing which we need to look at susceptibilities to third generation cephalosporin. So third generation cephalosporins are resistant, which means then next step is to look at BLBLI combination susceptibilities. Suppose if it is universally susceptible to BLBLI, like Dr. Neha said, then it becomes a pure ESBL. But since there is a differential susceptibility to BLBLI while retained susceptibility to carbapenem, and cefepime resistance tells that there are extra mechanisms like MC is also working in this particular isolate. So although this is a crude way to identify, now the guidelines are recommending more and more to involve genotypic identification of these culture reports. But based on this, I think this is bare minimum we can say that it's a purely a co-production of ESBL and MC in this particular isolate. And the choice of drug, we continued meropenem in this gentleman for another 4 or 5 days. And once he became kind of stabilized, it was de-escalated to ertapenem, which was completed as an opiate basis later on for 2 weeks. And he was changed to his diabetic drugs to gliptin and metformin. Why? I'll come to later on. And he was planned to undergo lithotripsy with DJ after 2 weeks as per urology advice. So I think having an understanding about the choice of drug in these kind of sicker patients who are bacteremic pyelonephritis, Merino trial gave us a very good data that if you see these ceftriaxone non-susceptible isolate, which means ESBL pyelonephritis, meropenem or carbapenem is better as compared to BLBLI. Even if it is, they are susceptible. So I think it is very important to pay lot of attention to this clinical nomenclature. Are we dealing with lower UTI, upper UTI, complicated, uncomplicated, what kind of setting it is, whether it is community acquired healthcare setting, because it has an implication towards our aggressive workup as well as the choice of the drug. And we definitely should need to differentiate between different urinary clinical syndrome in terms of asymptomatic bacteriuria, acute uncomplicated cystitis versus a complicated UTI. And this kind of different approach has to be tailored based on understanding the risk factor, and then only we can have a good amount of stewardship, be it inclusion of genotypic test to have a good diagnostic stewardship as well as a good clinical stewardship. Just to give you a brief input about understanding of complicated UTI, any male UTI, any UTI in diabetic patients, upper UTI in diabetic patients, pregnancy, any recent instrumentation was done, if there is anatomic or kind of functional abnormality in the obstruction system, if there are metabolic abnormalities, these are the points which makes an individual to have a complicated UTI, which means your approach has to be aggressive enough. And your knowledge of, yes, sir.
Only meropenem, or since aminoglycosides are concentrated in the urine, and so you would get a much higher concentration of aminoglycoside. So that may be synergistic, like you're dealing with the gram-negative bacteremia here, basically. So should you use just one antibiotic, meropenem, or should you use meropenem plus an aminoglycoside?
Yeah, so the problem with aminoglycoside in this case is that its creatinine is already 2.4. Number one. Number two, it is a bacteremic pyelonephritis, which means definitely you need, it's a high inoculum infection. You definitely need a potent antimicrobial. Third, problem with aminoglycoside, even if it is susceptible, it's a single point mutation. So you actually end up having a concurrent resistance if you use aminoglycosides in serious infections. So that's the reason carbapenem becomes a strong case in this particular setting. So moving on to the emerging risk factors, I think now we need to understand there are a lot drugs which are coming in our patients who have common comorbidities like diabetes. SGLT2 inhibitor is one such drug where actually there is a blockage of SGLT2 receptor in kidney, and which ends up having glucosuria in these patients, which is definitely not a natural phenomena. So there are a lot of glucose in the urine, which can have a precursor of development of complicated UTI. And there is a FDA warning to start to have a serious urinary tract infection with the use of these drugs. SGLT2 inhibitors have now moved towards the first line agent in most of the diabetic patients, even above sulfonylurea. So we need to understand about these emerging factors before we directly treat these patients. So just to remind you, this particular patient was initially started on a molecule called dapagliflozin, which is a SGLT2 inhibitor, and that's why he was having a lot of glucose in his urine report. Okay, just to pick your brain, this is another short case. The 23-year-old male, which is an engineering student at Manipal University, he is sexually active, comes with fever with chills, dysuria, cloudy and smelly urine since last 5 days. There was a frequent urination and poor streaming, dribbling of urine, pain below his penile shaft, which means you can understand he has a symptom suggestive of bladder outflow obstruction. He took nitrofurantoin after speaking to some doctor friend. There's no scrotal swelling, no flank tenderness. On evaluation, there was leukocytosis, numerous pus cells, and urine culture is pending. His ultrasound abdomen was grossly normal. So what do you think what is happening here? I think it's a clear case of upper UTI with bladder outflow obstruction. Possibly we are dealing with acute prostatitis. So why we need to understand all these factors? Because your etiology considerations might be different in somebody who is fairly young and sexually active and develops acute prostatitis. You definitely need to send blood cultures, and your treatment durations are longer in these cases. Unlike in this particular case, which is where there's a young lady who's a business executive, she comes with dysuria and urgency since last 2 days. There's no fever, no loin pain. She never had a sexual activity and denies pregnancy. So in such syndrome, we clearly can say that we are dealing with a probably acute cystitis, where we only need to make the diagnosis based on either symptoms or probably I think you don't need any fancy test to make these diagnoses. Can I have 5 more minutes? Yeah. So just to run through diagnosis of uncomplicated cystitis, even if you consider only symptom-based testing, 90% you are reasonably sure. While the dipstick test, which includes leukocyte esterase or nitrite positive, the sensitivity is only 75% and urine culture is least sensitive. So IDSA guidelines are very clear that in acute uncomplicated cystitis, you don't need to order any test, even urine routine. You need to treat these individuals based on symptoms only. And we also need to understand that this treatment is going to be short duration based on local epidemiology, and the goal is just to ameliorate symptoms, not to clear the asymptomatic bacteriuria. So there are a lot of tests available to us for interpretation, like we said leukocyte esterase and nitrate, but nothing is foolproof. Like there's a very good article in CID, although it's a very old article, but which clearly says that performance of gram stain and leukocyte esterase and nitrite, these are not really very specific. Even in the interpretation of the culture of urinary specimen, there's something called a high probability and low probability. High probability when the patients are not on antibiotics and directly giving samples. If it is one isolate, it has to be more than and equal than 10 to power 2 to become significant. If there are two isolate, it has to be at least more than 10 to power 5. By and large, more than equal than 3 isolates in urine has to be taken as contaminant. While in low probability, where patients are already on antibiotics, interop specimen, even 10 to power more than equal than 20 to power 2 isolates are significant. If they are one isolate, and if there are two isolates, it has to be in the same category. So I think these are the things which we need to understand. And then comes the interpretation of cultures, like we did in our case, because our problem is really bigger. Our predominantly gram-negative syndromes and our ESBL rates are high. So we definitely need to understand different resistance mechanisms. The commonly used drugs like quinolones are definitely not very useful in our setting, because the resistance are around 26 to 27%. And yesterday we discussed this regarding colistin MIC when we are treating complicated UTI in nosocomial setting. Even CLSI says that somebody who has a normal renal function and you give routine standard doses of colistin, probably you might lead to treatment failure. And we have a unique challenges, not only about clear understanding of microbiology report. We have a busy OP practice where there are a lot of other factors to prescribe antibiotics. So I think we need to, and we definitely need to refer these very relevant guidelines by ICMR in 2019. So I think with this, it's a very common infection. We requires a clear approach to understand, and a correct interpretation will only take us to a judicious management. Thank you so much for your patient hearing.
Thank you, Dr. Ravikant. I think we can discuss for the whole day such an important topic. My only take, if there are any younger people around, is whenever you have a male patient with UTI, there is no harm in a better way forward to involve a urologist or a surgeon, whoever is in your hospital, because male UTIs are usually complicated UTIs, and radiological investigations, local examination, epididymoarchitis, prostatitis, very common, especially in diabetic males, elderly people. And I think it is very nice to work together, because you would be seeing so many patients like hypertension, diabetes, lots of neurological patients and all. But then UTI is like just thrown away in the, just take levoflox or cephalexin or something like that. But the males, especially with the advent of the drugs that you mentioned, pyelonephrostitis is such a common thing. And that is again like going up and up migrating and going into prostatitis and then ultimately pyelonephritis. And to answer Sir's question about giving amikacin, as you rightly mentioned, but once the kidney is drained, sir, once it is drained, then we don't need those many antibiotics also, because the pus is off now. So I think it's a very good presentation. I wish we had more time to discuss with you. Thank you very much.
Thank you. Yes, Kiran. Yeah, it was.
I have a slight, difference of opinion on this, because sir, when you talk about GFRs, and it's for chronic kidney disease. And these are drugs which are like chronic drugs which are given, and then you modify doses. For an antibiotic, when it's an AKI, I think first 48 hours we should go full on, sir. We should not hold back. We should just fire all the bullets in the gun.
Yeah, I understand. I think points well taken, but his baseline creatinine was 1.2, which means it was a pure AKI. Thank you.
Actually, I have just a little query. I'm being a microbiologist, so that AMC and the ESBL business you showed, actually AMC, the cefepime gets paired in the AMC. It's not, it does not get affected because it's a zwitterinoid ion, so it gets, it is able to pass through the membrane. That could be the one reason, but the other reason could be that all ESBLs are not affected by the various BLIs equally. So we have got a combination of tazobactam, sulbactam, clavulanic acid. So sometimes you have got a different, these BLIs which get affected by, which the drugs can affect and certain drugs cannot affect. So it could be the differential activity of the drugs on the ESBL rather than the co-production of the AMC in the ESBL. That can be the reason also.
Okay, thank you.
I'm a nephrologist, Dr. Anurag. My message is never treat asymptomatic. Patients comes to us from various places, pus cells 10 to 15, they are on various antibiotics. There should be symptoms, either lower urinary tract symptoms or upper urinary tract symptoms. Treat only two conditions. One is pregnancy and another is early transplant if it is less than 1 month. So this is very common in practice. You see the pus cells, no symptoms, you treat them. You do a urine culture, patient is asymptomatic, you treat it. So it causes the antibiotic resistance.
Thank you.
But no urinary tract symptoms. No complaints at all.
So I think
And pyruvia, you will treat only in pregnancy and early transplant.
so I think we
So,
can take
yeah.
further questions later.
Thank you.
We'll thank you, Dr. Porwal and the moderators. We
So
move
there's
on to
one
the
more. I mean, we had such a lovely session here, and as Dr. Manu Gupta said, that we need to work in collaboration for UTI. There has to be collaboration between the urologist, nephrologist, and I think physicians and infectious diseases. So please involve them as well.
I'd like to call upon Dr. Shakti and Dr. R.R. Datta to chair the next session. Dr. Shakti is a well-known consultant in medicine at Apollo Hospital, Delhi. And Dr. Datta is HOD medicine at Paras Hospitals. I'd request you to introduce the topic and the speaker.
Do we have it written down? No, but I don't. There's this only. Oh. No. Good morning, everybody. I now request Dr. Parvinder Chawla, who's a consultant and senior consultant in internal medicine in Fortis Hospital, to please come and give her case presentation. Very rightly termed twists and turns. Thank you.
Good morning. Thank you, Chairperson. Thank you, Dr. Neha, for having me here. It is a privilege to be able to speak in front of my seniors and teachers. So Dr. Neha asked me to present an interesting case related to ID. I would like to express my gratitude, and this is a disclaimer that this is not my own case per se. So I'm thankful to my ICU team, critical care team, the pulmonologist and the lab medicine team for having shared this case with me so that I can present it here. So we have a 63 years old lady. She's a resident of Noida, had underlying rheumatoid arthritis for which she was on HCQS and had received a methotrexate for a while. She has hypertension, recently detected to be having diabetes, for which she was on OHAs. And in January this year, she had redness of one eye, probably diagnosed iridocyclitis outside. So she was visiting her daughter at Roper, which is a small township about an hour away from where we practice. And in beginning of April this year, she started having nausea, decrease in appetite, slight burning, micturition, for which a UTI was documented, and she was started on nitrofurantoin. She continued to have lingering symptoms, but then worsened rapidly on about a week later on 8th of April. And a day later, she had marked worsening in dyspnea. So with these symptoms, she was admitted at Roper, and her saturation at that time was documented to be 64% on room air. She was started on high flow nasal cannula, started on meropenem, clarithromycin, and she continued to deteriorate. Her HRCT chest showed ground glass opacities with septal thickening and consolidation bilaterally, and few lymph nodes, pretracheal, prevascular, subcarinal, and bilateral pleural effusion was present. She continued to deteriorate, developed hemoptysis. At this juncture, she was started on remdesivir and voriconazole. She was not improving. Her X-ray, as shown here, is showing bilateral opacities, more of alveolar infiltrates. So at this juncture, she was the family contacted Dr. Mandal at our hospital, and shifting was planned to our hospital. She was electively intubated before shifting, and at admission to us, her saturation was 65% on like full flow oxygen, and blood pressure of 200 by 110. So she was stabilized, shifted to the medical ICU. The initial investigations that we received after taking her in were a slightly low hemoglobin of 9.4, elevated counts, 23.5 with 89% neutrophils. Platelets were okay. There was slight liver and renal dysfunction also with creat of 1.6, slightly increased bilirubin. OTPTs were surprisingly reasonably fine, but LDH was quite elevated to 158. She had elevated INR and D-dimer, CRP, PCT were elevated, and A1C was slightly elevated, but almost okay. So at this juncture with this profile, the differentials that were kept were a diffuse alveolar hemorrhage versus acute interstitial pneumonia. She was already on meropenem, which we continued, and we added a Septran because the LDH was very, very, very high, and we didn't have any logical explanation for this rapid worsening. Her COVID, this was done outside, which was negative. With us also, it was negative. Her biofire film array did not show any organism per se. And so the treating team narrowed down to diffuse alveolar hemorrhage, keeping this whole thing in mind. We had sent an autoimmune workup at this juncture and discussed with the family regarding the option of high-dose pulse steroids versus IVIG or plasmapheresis. Because of the high biomarkers in terms of the CRP, PCT, the decision for giving steroids was withheld. And it was decided to give her IVIG, 2 grams per day over 2 days, 2 grams per kg per day over 2 days, and she was started on the proning protocol. So her autoimmune workup was also like almost negative, with ANA was just marginally elevated at 1 + 1:80. After completion of IVIG, she was started on methylprednisolone, 40 milligrams twice daily. She did show gradual improvement after that. She was rather extubated on 19th of April. She was maintaining oxygen on nasal prongs at this juncture. She was switched from injectable to oral steroids. A right cheek erythematous lesion was noted at this juncture, which was attributed to probably a pressure sore because of prone positioning. And we sought a plastic surgery opinion for the same. I would just like to hold the presentation here for 10 seconds. If there's any input from the team here, from the audience here. So we have a patient, 63 years old, rapidly worsening with type 1 respiratory failure. We have not been able to get the diagnosis, exact diagnosis. The clinical suspicion is of DAH. She responds beautifully to steroids and to meropenem and Septran. But at this juncture, we have a right cheek lesion, which is probably a pressure sore. The plastic surgeon says that this will heal and we need not do anything. So we sort of, the team went with the flow here. Her oxygenation improved, and rather within about 8 days of admission, the lungs have almost cleared out. But the cheek lesion had worsened by this time. It became black, resembling an eschar, and she also had pain right eye. At this juncture, the treating team thought of Mucor. It was surprising. We had never seen a Mucor developing in front of our eyes, but so obviously a CT was done at the juncture, and they were quite satisfied to see that the sinuses were relatively clear. As you can see that there is a slight amount of, I don't have a pointer, but on the right cheek, there's a slight amount of swelling there, but otherwise the sinuses are relatively clear. So eventually we did go in favor of debridement. The lesion was quite deep in the intraop thing, and it was well debrided. And the KOH mount showed broad aseptate hyphae with right angle branching. So we had started her on amphotericin at this juncture. Repeat CT again luckily showed that the sinuses were cleared, and we see this soft tissue defect, which is a post-op defect here. Daily dressings were done with topical local amphotericin B cream. Both the culture and the histopath subsequently confirmed Mucor. So here in this one, we see the white, the left upper panel, the white fluffy growth of Mucor. And this is the lactophenol cotton blue on the right side upper panel. The histopath and the H&E stain again shows the same hyphae, and that is the GMS stain showing the black fungal hyphae of Mucor. Wound healed gradually. We see the rich red granulation tissue here. So basically, she's tolerating ampho. Okay, that's okay. She's tolerating ampho well as of now. So basically, this was a case of nosocomial cutaneous Mucor developing in a patient with rheumatoid arthritis, hypertension, diabetes, with acute respiratory failure, which is probably DAH or PJP. We don't know for sure. And so this is the scenario in India of mucormycosis. We all know that the rhino-orbital cerebral mucormycosis is the commonest, and that is what probably is there in our mind when we think of mucor. And cutaneous is the second commonest, though, followed by pulmonary, renal, GI, and the disseminated ones. And out of all the fungi that are clubbed under this group of mucor, Rhizopus is the commonest. For our patient's culture, we still have to see the granulation, still have to see the sporangium formation. We do not know which one are we dealing with. But nosocomial mucor is a reality. And here in this article by Dr. Chakrabarti, they say that 9% of all cases of mucor are nosocomial in origin. And the commonest reason being the adhesive tapes that we use, or the ECG leads, or the IM injections. So we are not sure, but this is the location where usually the Ryle's tube is fixed, sometimes over the forehead, sometimes over the cheek. So was that the culprit or the cause in this patient? We can't be sure, but then she did have other risk factors like diabetes, steroids, the pressure, trauma related to that. She was on voriconazole for about 2 or 3 days before coming to us, and critical illness per se. And this was something new to me, that there's this thing called breakthrough mucormycosis, which can happen in patients who are on voriconazole. So this is a case report from AIMS, I think, where a patient was on voriconazole and developed a mucor subsequently. So the lessons that we learned from this case is that nosocomial mucor is a reality. We need to suspect it early. Quick diagnosis, prompt initiation of treatment can save the patient from this devastating infection. And amphotericin B combined with good debridement and daily dressing is needed for optimal management. Thank you.
Any comments from the audience, please, or any queries? In fact, this is a very interesting case. We must keep our eyes open, so anything can happen. ICU setup, pressure sores, adhesive tapes and all those things. So any comments from the audience?
How
the pulmonary involvement is good. Because you had interstitial and fluffy infiltrates, hazy
So
infiltrates.
those things improved and then this lesion developed. So the lung lesions were not mucor. The tracheal secretions did not have any fungal hyphae. So that part improved with steroids and this developed subsequently. I don't have the initial pictures because the team said that it is all pressure. I mean, nobody even thought of taking the picture initially of that initial redness. I couldn't get that picture. The A1C was 6.8. The sugars were reasonably, I mean, not very bad, but less than 200. I mean, that was not the major culprit, I would say. But yes, he was a diabetic. He is a diabetic. Diabetic, steroids, pressure, varicose. COVID negative. Outside, she did receive remdesivir, I mean, as this thing, but then that was only probably 1 dose or 2 doses.
Ma'am, I have a question. Yeah. Thank you for this case. Really very enlightening. Ma'am, what led you to start the patient on Septran in the first go? Like you are saying the LDH was high.
So there is a concept, I think Dr. Neha also mentioned yesterday, that LDH to PaO2 ratio, if that is more than 4.5, that has a very high specificity for thinking of PJP. HID all was negative, but then this rapid worsening, a rapid time for respiratory failure developing only over about 2 days with the lung picture or the X-ray showing such a picture and very high LDH. So the treatment team thought that apart from the common pathogens, and then the biofirewall was all negative. So no gram negs or anything picked up. So at that juncture,
that was a very good decision, like a very good clinical this thing. Ma'am, one more question is that did you think of going for a bronchoscopy anytime? Because they
critical and the treating team was almost sure that this is probable DAH or this. So and she was she responded beautifully to steroids.
Yes. Okay, ma'am. Thank you.
Thank you.
Our next session is PCR to Petri, revisiting the conventional microbiology. For this session, I'd like to request Dr. Neeraj Goel, who is Senior Consultant Microbiology at Sir Gangaram Hospital, and Dr. Meghna Kabra, who is Senior Consultant Internal Medicine at Patra Hospital, New Delhi. Dr. Ashima Jain Vidyarthi. She's an Assistant Professor at NCI Jhajjar AIMS.
Okay, I would like to thank Dr. Neha for giving me this opportunity to speak here. So I shall start with the thought that we should have the wings to signify the belief in ourselves to reach for the stars, while in the process we should not forget our roots from where we started. So the roots here are the conventional microbiology techniques. So good morning, greetings from the National Cancer Institute, AIMS. So we all know that what are the advantages and disadvantages of molecular techniques and conventional techniques, and I'm really not here to judge or decide which one is better or worse. It is really a case-specific discussion, and I'm just here to present a perspective. Why are we discussing this today? Because out of the more than 1 million labs running in the country, only 3,300 could rise up to the occasion for COVID testing when we needed it in an emergency situation, and that too over a period of 2 years. So this gives us a vague idea of the status of molecular testing in our country, and clearly it cannot be used as a mandate for diagnosis of infectious diseases. And so not only do we need to scale up our molecular testing in the country, but also try and rely on the conventional diagnostic methods. So let's start with the basic technique of microbiology, the microscopy. We have a very common myth these days that microscopy is an ancient technique and does not serve much purpose nowadays. While the reality is that microscopy is the oldest, yes, the simplest, most inexpensive, and one of the most efficient methods of diagnosis even today. So these are the regular critical alerts that we have in a NABL accredited microbiology lab, and we are able to make diagnosis and initiate treatment just on the basis of these critical alerts. Simple AFB positive samples, gram-negative seen in gram-negative bacilli seen in CSF or a budding E cell on the basis of gram stain or maybe a India ink or a hanging rough positive. All these are critical alerts, but what if I talk about the normal flora? So whenever a clinician sends a sample to the microbiology lab, they should be aware that what normal flora can be expected or reported in this sample. So if we are reporting a gram-positive cocci in a sputum sample, it does not necessarily require treatment. While if that report is coming out in a sample which is expected to be a sterile fluid, then definitely it needs to be taken with a pinch of salt. So like a GNB or reported in a CSF, definitely you should consider treating it. So the question here is, can we escalate or de-escalate the antibiotics based on the basis of a gram stain? That is a basic technique. So my take on this is yes. And these are the various studies to prove it. These have been done throughout the world. The first one is from India. The others are from Japan. So the latest trial is the GRACE-WAP trial, published this year itself, which have been, the results have been encouraging, and they have showed that the gram stain guided treatment was non-inferior to a guideline-based treatment and has significantly reduced the use of broad spectrum antibiotics in patients with VAP. Going ahead, this was a case series that we published on a very interesting observation made microscopically on gram stain itself. So I will just present this one case. 75-year-old gentleman, known case of diabetes and hypertension, presented to us to our emergency with complaints of sudden onset high-grade fever, difficulty in breathing, progressively worsening. He was started empirically on ceftriaxone and vancomycin along with the other supportive measures. He had a recent history of prior ICU admission for similar complaints. The chest X-ray was suggestive of left lower zone opacity, and the blood picture showed leukocytosis. So the gram stain of his sputum sample showed us these filamentous structures with a central enlargement. And some of these filaments were even, they were surrounded by unstained zone suggestive of a capsule. The culture grew Klebsiella pneumonia, and it was an ESBL producer. So we dug up the literature and we found that such forms have been reported in other gram-negative bacilli like E. coli or Pseudomonas. And as we say, I see what the mind knows. And subsequently, we came across 5 or 6 more such cases where we saw these filamentous structures, spindle shaped, and all of them for us grew Klebsiella pneumonia, either carbapenem resistant strains or ESBL producers. So we further looked up the literature, and it was there that when the gram-negative bacilli are exposed to suboptimal doses of antibiotics because of intermittent therapy or low dose therapy, especially beta lactams, a stepwise cell lysis happens, leading to morphological changes there. And that is why these morphological changes happen. And these filaments may be progenitors to spheroplast or protoplast formation. And they are involved in occult chronic infectious processes or recurrence of overt infection after discontinuation of antibiotic therapy. And further research is required, but they might be suggestive of some marker for resistant strains of infection. And hence, we came up with this conclusion that the microbiologists should be made aware of such aberrant forms being seen, because to avoid any confusion with fungi or other filamentous bacteria. The clinicians, on the other hand, should be informed if such forms are being seen on the gram stain, because it may be indicative of subtherapeutic concentrations being achieved at the site of the infection. Also, we should strictly adhere to the classical practice of doing a gram stain or basic stainings for all the samples that are received in the lab. They can give us very useful information and help us guide the therapy for the patient. Moving forward, this was just a small piece of data that we is ahead of publication, but last year during the second wave of the COVID pandemic, we were told that we have to set up a mucor ward in the hospital, and suddenly we were told, we were in the process of setting up our lab, and we were told that we have to start the diagnosis for mucor, and we just had the facility to start the microscopy and not the culture. So we started just that, and within a span of 1.5 months, we got 75 samples from 50 patients, majority tissue biopsies and nasal crusts. And out of those 75 samples, we could diagnose 70% of the patients just on the basis of KOH microscopy, as well as a good clinical suspicion. The only precondition was a good and appropriate sample, which is a precondition for any other modality to be effective. And hence, KOH microscopy was thus a reliable, inexpensive, and a valuable modality for presumptive diagnosis of these cases. I understand that the absence of culture was a limitation in this scenario, but considering the criticality of early diagnosis and our desperation for starting the treatment, that the culture being a time-consuming modality would not have been so helpful like microscopy, especially in a resource-limited setting like ours. For the molecular methods, although I agree that they are rapid and reliable, but they do need a sophisticated infrastructure and a high degree of technical expertise. Also, interpretation for PCR for mucorales is just challenged due to environmental contamination. We have had some papers showing molecular tests providing encouraging results from blood and serum samples like this one. But the sample size here was really small, and these assays are still under research and are associated with poor specificity and sensitivity if they are being used as standalone tests for diagnosis. And hence it is recommended that they be used only in conjunction with conventional microbiological techniques. Further, this paper this is a review actually, which was published last year, and they have reviewed a lot of papers with rapid diagnostic tests for smooth functioning of the emergency department, and they have included all tests which have a turnaround time of less than 2 hours. So they have included not only immunochromatographic tests, but also tests like BioFire and Gene Expert and VIDAS for that matter. But they came to the conclusion that RDTs cannot replace conventional methods because they are not exhaustive and they have performance limitations and provide limited data on antimicrobial susceptibility profiles. So my concern here was also that not everybody can bear the cost of these big instruments like BioFire and Gene Expert. Also, the cost per test for modalities that provide single sample testing like BioFire, Gene Expert, and even VIDAS is exorbitant as compared to those where batch testing is performed. And if adequate sample load is not available for a batch testing, and we have to wait for the batch to adequate samples for the batch to be there, then the whole purpose of running those molecular tests for an urgent report is defeated. So it's a confusing situation that way. And running the molecular test directly from the specimens again is a confusing situation because the viable and the non-viability of the organisms we don't know. And further, false positivity due to contamination and false negativity due to the inhibitors is also a problem. Yesterday, Dr. Parikshit also mentioned that whatever the BioFire reports is not always significant. We have to correlate it with the clinical condition. And this BioFire test, although I totally agree that it is a wonderful test for early diagnosis, but again, even if it identifies the bacteria and the gene resistance gene, it does not tell you which gene and which gene is associated with which bacteria. The bacteria may not be even viable. So we again have to correlate it with the conventional tests. And are these rapid tests really that sensitive and superior? This is preliminary data from our lab. We had this stool antigen test available they committed a sensitivity and specificity of almost 99 to 100%. 20 samples were tested here, 19 came negative, 1 came positive for Giardia. And out of these 20 samples, 4 were positive on microscopy itself. So I really don't know. This is a preliminary data. We'll need more such data to come to any conclusions. This is okay. So another myth: cultures are too outdated, overrated, and time consuming. Why waste time when we can do molecular tests? So the reality is that cultures are the single most important diagnostic modality for infectious diseases, which not only help us identify the organism, but also know the significance and susceptibility pattern. They are indispensable for preparation of antibiograms and are economical and less technically demanding than any other molecular test. So this, I'll just wrap up in 5 more minutes. This is a case that we had encountered. 32-year-old male came to our emergency with painless lumps in bilateral axilla and on the sides of the neck. Multiple episodes of vomiting and low-grade fever, is history of easy fatigability, but no loss of appetite and loss of weight. There was no history of any cough, chest pain, shortness of breath, and night sweats, and no past history of any diabetes, hypertension, TB, or any other disease. The general physical examination showed generalized lymphadenopathy and icterus. He had leukocytosis and thrombocytopenia. The bone marrow examination was suggestive of non-Hodgkin's lymphoma. So he was given the anti-cancer treatment, and on the 12th day of admission, the patient developed fever. WBC count was reduced from 17,000 to 6,000, and the patient was started on cefiperazone sulbactam as per the hospital antibiogram, and multiple blood cultures were sent before starting the antibiotics, and the blood cultures came out positive within 10 hours, but they had already escalated the patient because he was deteriorating continuously to meropenem and teicoplanin. The gram stain of the blood from the blood culture showed GNB, and we were actually expecting it to be a carbapenem resistant strain, considering that the patient was deteriorating on meropenem, and the clinician was actually considering to start polymyxins. But just then we grew this organism, which was not looking like a regular enterobacteriales, and the next day the report from the automated system came out to be Chrysobacterium indologenes, which was actually resistant to all of the routine antibiotics, including carbapenems. So we just told them, stop everything and start injection levofloxacin, and the patient became afebrile within 2 days. Subsequent 2 blood cultures yielded no growth, although the patient succumbed on 26th day of admission due to the primary disease condition. But then, yes, here I agree that we use the automated system, and all labs may not be able to procure that too. But then we here are comparing between molecular and MALDI-TOF with the regular biochemical tests that we are doing in the labs. So why was this important? Because it was a rare pathogen and a very common environmental contaminant. It is resistant to the routinely used antibiotics, and it is notorious for forming biofilms, especially in patients with indwelling catheters. Repeat isolation is the key to decode the pathogenic status, and targeted therapy was really important here. So this case highlighted the significance of right diagnosis and diagnostic stewardship and timely microbiological diagnosis. To summarize, molecular tests are undoubtedly the way ahead. However, conventional tests are still indispensable and should not be abandoned. Combination testing is the need of the hour. For the microbiologists, go out there, go out of your comfort zone, interact with the clinicians, and let the magic happen. And don't forget, microscope is your friend forever. For the clinicians, trusting is hard, but knowing whom to trust is even harder. So always trust your microbiologist. This is a very good paper by IDSA. I suggest you read it. And this is my team from our department. Thank you. Any questions? I don't think so, sir.
Phosphomycin, the phosphomycin is not a classical drug for the treatment of this very atypical bacteria. It is basically used for only E. coli and Enterococcus faecalis. People have been using it as a salvage therapy, but more or less what happens is that when you're doing initially in vitro sensitivity may be there, but subsequently because of a gene which gets induced and produce resistance, so these are not very, very effective drugs. One should not.
I don't think this organism is under the spectrum of fosfomycin. So
Yeah, still people sometimes use because it's in vitro sensitive, but it's not to be really trusted on. So thank you, Dr. Vidati. Actually, that was very brief, but really very comprehensive and very lucid presentation. I would just like to add, rather, I like to concur with you is that, these conventional and molecular, they are not exclusive of each other, but they're complementary to each other. Like in our experience, if your patient is having a meningitis due to Streptococcus pneumoniae, it is very, sometimes we directly get a biofire sample. And instead, if we could have just got a gram stain and we could have seen gram-positive diplococci, we could have given an answer in just 200 rupees in just 10 minutes rather than spending 12,000 rupees in 2 hours. So there has to be a process, a method where you first screen and look for the number of pus cells, whether it is low, because in low pus cells, you need sometimes you can exclude the bacterial etiology. And the second point is that by looking at the morphology of the bacteria when they are growing in the cultures, like today we have got Klebsiella, which are hypermucous Klebsiella. Now these hypermucous Klebsiella are actually, they are very difficult to treat even if you give the antibiotics, because they tend to get stick to your lines, the center line. So these information you cannot get from the molecular biology. So the molecular biology is definitely going to help, but we have to stick to the roots, which you started with the line. So it was very, very, very beautiful presentation.
Thank you, sir.
Thank you, Dr. Ashrama. Very nicely.
We had this one question. Can we take this one question?
Yesterday we had conversations about various parasitic infections and fungal infections and HIV patients which are very difficult to diagnose. So just to add to what Madam Bansal has already added, that's a simple thing that even for you will see if you're suspecting mucor and you send it to a microbiological lab, you'll get a call in another 1 hour or 1.5 hours if it's a tissue that's it's showing broad aseptate hyphae. And you can start the patient and you don't even have to wait for the culture reports. You start the treatment of the patient. The similar is the picture for, if you are even culturing any fungus, there are certain which grow very, very fast. Cryptococcus, penicillium. Yesterday we saw a case of cutaneous penicilliosis. So they grow so fast, so you don't have to wait for PCRs and some bigger names in that scenario to give a diagnosis or to help the patient. And same is for parasitic infections. Even a simple wet mount can guide the clinician as to how to go. So for everything, biofire or PCR is not the answer. Of course, it is the answer in complicated cases where you have ruled out everything by wet mounts and basic etiologies.
Rightly said, Dr. Vibha. Yeah. Thank you, Dr. Ashima.
Just a submission. I'm a physician and I learned a lot of ID from my microbiologist. My interest in ID was because of my microbiologist. So I think all physicians and all ID specialists, I mean, you cannot work without your microbiologist. You need to keep on meeting them and talking them. Thank you.
Thank you. So we move to our next session, that is inauguration. I request Dr. Neha Gupta to invite the chief guest for inauguration.
Hello.
So, good morning. We welcome you all to the first Delhi NCR chapter of Clinical Infectious Diseases Society. And as we all know that infectious diseases has cut across the usual boundaries set by the medical specialist. We are dealing with infections in and out, and it is not just physicians, but clinicians, surgeons, each one of us have to face complicated infections in our daily practice. And so many investigations are done, and it's important to interpret them. So that is why we have the theme for the Delhi chapter as interpretation of the interpretation in infectious diseases. With this, I actually welcome all of you today, and I request our president, Dr. V.R. Subramaniam, to kindly come onto the stage. Sir needs no introduction. He is one of the pioneers in the field of infectious diseases. He has started off the training program of FNB infectious diseases way back, and it takes a lot of courage as well as the initial struggle to establish a particular specialty, and the credit goes to all of them who have done this. Sir is also senior consultant in Apollo Hospitals, Chennai, and is the director of Cape Town Clinic, a very well-established clinic in Chennai. I request Dr. Atul Gogia. He is the senior physician in Sir Gangaram Hospital. Now I request Dr. Atul Gogia. He's a senior physician in Sir Gangaram Hospital to come and take the seat. I request Col Sumit Arora, who is a senior physician with a special interest in infectious diseases, who is at the base hospital, to please come here as well. We have our treasurer, Dr. Sunita Reddy here. Ma'am, please give us the honor and come onto the stage. Now, with all of your permission, we are privileged to have a guest of honor, Mrs. Urmi Mala Barua. She is Mrs. India World, and she is the CEO and founder of Queen of the World India. It's a basically initiative for empowering women, and I have known Urmi Mala Barua as my connection as an infectious diseases specialist, and it's an honor to have you here.
I request Dr. Neha and Dr. Sunitana Reddy, madam, to hand over the bouquet to her. Madam, thank you so much for gracing this event with your presence, and we all are fortunate to have you here. Thank you.
So we will begin with the Ganesh Vandana now, please. And light the lamp.
गणपतये नमो नमः श्री सिद्धि विनायक नमो नमः.
I request Dr. Khanna as well, and Dr. Sangeeta Nag, ma'am, please come. Please come.
बाप्पा मोरिया. गणपतये नमो
Dr. Atul
नमः
Kakkar.
श्री सिद्धि विनायक नमो नमः. अष्टविनायक नमो नमः. गणपति बाप्पा मोरिया. गणपतये नमो नमः श्री सिद्धि विनायक नमो नमः. अष्टविनायक नमो नमः गणपति बाप्पा मोरया गंगणपतये नमो नमः श्री सिद्धि विनायक नमो नमः अष्टविनायक नमो नमः गणपति बाप्पा मोरया
So I will request Dr. Ankita Baidya to please give the bouquet to Dr. Atul Gogia. And also to Col Sumit Arora. So I will.
I request Dr. Neha Madam to hand over a bouquet to Dr. Sunitana Reddy, a treasurer of our CIDS, Clinical Infectious Disease Society. Madam, thank you for coming here in Delhi and gracing this occasion. And I will request Mr. Satyanarayan to hand over the bouquet to Neha Madam for holding this. Madam, from on behalf of us, thank you so much for. Just hold for a minute. Yeah.
So now I will request our society president, Sir V.R. Subramanian sir, to inaugurate the session with a few words, please.
Good morning, everybody. It's a pleasure to be here this morning in Delhi. It was a little shocking for me. I come from Chennai, which is very warm. I landed at 8 p.m. last night, and the air hostess tells me that the outside temperature is 41. You know, that shook me a bit, but having come here, I find it's so warm. Your hospitality, your welcome. So thank you very much, Dr. Neha and Dr. Gogia, for this invitation. The Clinical Infectious Diseases Society of India is a very relatively young organization, which has membership of people who are interested in management of infectious diseases. It is growing very rapidly, and thanks to my colleagues, Dr. Priscilla, who's unfortunately couldn't make it here, who's a secretary, and Dr. Sunita Reddy, who's a treasurer. I think we have a lot of plans for expanding the base of the Clinical Infectious Diseases Society. We need more people who are interested in infectious diseases, physicians, microbiologists. It does not matter. I think we need to add numbers to ensure that infectious diseases comes up as a strong force, which is evidence-based and is able to come up with guidelines for management of various conditions. On this aspect, we are trying to increase the visibility through opening of more chapters of CIDS all over India. And we have already had in the South Kerala and in Pune. And now I'm happy that Neha and Dr. Atul Gogia have initiated this the Delhi NCR CIDS chapter, which I think is a very good initiative. We need all your support. And I would also like to mention in this regard that the Clinical Infectious Diseases Society Conference, the CIDSCon for 2022, is being held in Kolkata on the 14th, 15th, 16th, 17th of July. 14th, there is a pre-conference workshop, and the 15th, 16th, 17th is a conference. So I would like to invite all of you to participate and make sure that our fight against infectious diseases fructifies. Thank you once again, and I hope you're having a very good conference here, what we had yesterday and also today. Thank you.
Thank you so much, sir. And now I invite our guest of honor, Urmi Mala Barwa, to say a few words, please.
A very warm good morning to everyone. It is such an honor and a pleasure to be here this morning. I extend my a big thank you to Dr. Neha for having me here today with the Clinical Infectious Disease Society. I am Urmimala Barua, Mrs. India World 2019, and the founder director of Queen of the World India Beauty Pageant. Basically, I'm from the beauty industry. It is an empowering program for women from all walks of life. And we do have a lot of doctors who represent India in different international platforms like Mrs. World and Mrs. Universes, and have brought so much of pride to our country. And Dr. Neha was also a participant of our pageant, so I'm really honored to have her with us. Talking about infectious disease, I am sitting with the pioneers of medicine, so not the right person to talk about medicine. However, the one thing I relate to Dr. Neha and infectious disease is I truly believe that raising awareness and prevention is of utmost importance. Having lost my husband to resistant tuberculosis, I truly think that this is something, I'm sorry. I'm really honored to be here today. And thank you, Dr. Neha, for giving me this honor. I think he's up there and remembering me and really thanking me to promote such a noble cause. Thank you.
Yeah, so this is absolutely true. And it just emphasizes that how important it is to raise awareness about infectious diseases. A lot of it can be prevented, especially we have tuberculosis, drug-resistant TB, complicated infections, antibiotic resistance, in common infections which can actually kill if not picked up early and treated appropriately. So this is something which we all as a society, as well as create awareness among general public, as well as the specialists who actually treat it. Yeah. So I'll request Col Sumit Arora to give the vote of thanks, please.
I'll start with thanking Ms. Urmimala Barua to be here, gracing this occasion. Thank you, ma'am. And Dr. V.R. Subramanian, President CIDS, thank you very much, sir, for your physical presence here, gracing the occasion and encouraging us. Dr. O.C. Ibrahim, guiding light of ID in this country. He was kind enough to send an online lecture and bless us. Thank you, sir. Dr. Priscilla, who's not here, but was very supportive of this first Delhi CIDS chapter. Thank you, ma'am. And Dr. Sunita Naredi, thank you very much, ma'am, for being here, for encouraging us. And mostly Dr. Neha, whose brainchild this first Delhi CIDS chapter is, who's pushed everyone, all of us to conceive this first Delhi CIDS chapter. And Dr. Atul Gogia, whose efforts actually made it possible. He and Dr. Neha were the two main people, driving force behind this conference actually happening. Thank you, sir. Next, I would like to thank Dr. Nitin Bansal for actually doing all the on-ground work, making sure that all faculty arrives and is well taken care of. And Dr. Ashima, actually, we did not think that we will be able to have a poster presentation. The time was too short, but it was magical how she managed to do it in 5 days, get all the posters and get them presented. Thank you, Dr. Ashima. Thank you all the faculty for making this possible, for being here, for making your presentations and being part of this chapter. Thank you very much. Thank you all the delegates. Lastly, but not the least, we have to thank the MCure team who made this possible. Thank you, Mr. Satya and his team. And thank you, Taj Hospitals, for their hospitality. Thank you all. And I think we should move on with the next session. Thank you, everyone.
Hello.
For the next session, I would like to invite Dr. Atul Kakkar, Senior Consultant, Gangaram Hospital, to please moderate the session along with Dr. Ankita Baidya from Manipal Hospitals, Dwarka.
So this session is going to be very interesting. It's about eye involvement in ID. And the speaker is Dr. Amit Khosla, who's the senior consultant in ophthalmology in Sir Gangaram Hospital. And it's usually said that eye is a reflection of internal diseases. So let's see what are the diseases he can pick up and inform us about. Thank you.
Good morning, everybody. The eye is a window to the body. It's the only place we can see live blood vessels. We thought that this disease would reduce with mass, but we find that tuberculosis is on the rise after COVID. We're finding patients who come in late with choroidal tubercles, and sometimes eye is the presenting feature. So the uniqueness of TB is that you may have an isolated eye involvement without any other involvement in the body. Infections can come at the primary care level, in the emergency, or in a hospitalized patient, as you have been discussing for the last 2 days. The eye involvement is generally from the bloodstream, metastatic as we call it, or it can come from the sinuses like orbital cellulitis, like mucormycosis, which comes in from the sinus. And secondly, if you're immunocompromised, you're higher risk. So eye is an organ which has high flow of blood. So choroid is one of the areas where the bacteria come and settle down. So basically we have two barriers, the blood retinal barrier and the aqueous, the iris barrier. So when these endothelium of these vessels break down, then bacteria or viruses travel into the eye. So at times the patient is sick, doesn't report any symptoms or signs, And it rarely, like in candidiasis, the eye problem can be presenting feature. I still remember in my senior NC, there's a patient with a gunshot injury who was having fever post-op and abdomen, and just complained of mild blurring, and we saw white ball candida in the vitreous cavity, and the patient responded to antifungal. Sometimes the eye can also be the area for diagnosis. Unfortunately, we cannot take out a sample. So the maximum sample we can take out is say 0.2 cc from the aqueous, or from the vitreous, which is full 3 ml. So sometimes we had loss of giving the volume, and for PCR or any other thing, the microbiologist always asks at least 1 ml. Where do we take out the fluid to culture that bacteria, this thing? So eye is not, the cornea is avascular, so it is, but the choroid at the back is highly vascular. So we can have infection or its sequelae, but unfortunately, the patient may be fine, but we left with visual morbidity on the long-term basis. So we can have bacteria, fungus, virus, or parasitic. As discussed, mucus. So basically from the sinuses, you get first a preseptal cellitis, then the orbital cellitis, then you can become a subperiosteal abscess, or an orbital abscess, or cavernous sinus thrombus. So it's important that if you have a patient who has lid edema, a CT scan will add with the sinuses, helps us diagnose the orbital cellitis earlier. While for the intraocular, it can, as we mentioned, endogenous. It may occur simultaneously with systemic infection and can be the only apparent infection. For what us the dilemma is that uveitis or inflammation of the uveal tract can just present with a hypopyon. It could be ankylosing spondylitis, or could be a life-threatening metastatic endophthalmitis. So we need to dilate the patient and see. And when we dilate, we see tubercles, we see subretinal abscesses, or a white fungal, white-like picture in the anterior chamber. So we have to evaluate the patient total, and sometimes difficult to do a bedside evaluation. And majority of these patients, as you've been discussing, have been uncontrolled diabetes, cardiac issues, GI malignancy, or indwelling catheter, which can also cause sepsis. The treatment is high-dose systemic antibiotic, but it doesn't penetrate the vitreous. The vitreous is like a culture medium. You need to inject into the vitreous. We normally inject a combination of a vancomycin for gram-positive, gram-negative, and depending on the sensitivity, certain drugs are allowed to be injected into the eye, which has a safety issues. So this patient presented from another hospital with a sternal abscess of pseudomonas and gradually lost vision. So you see a patient who has full of vitreous. So we had to go in and so normally what we do is we go in through 3 ports, one for infusion, one for light source, and one for cutting. So we have a 3-port like. So we take this probe in and we remove the vitreous, but the membranes were stuck to the lens. So we had to sacrifice the lens also. So that's what we just call vitreous surgery, and where we remove the pus and send for culture. So what we do is it's total 3 ml. We first take out the fluid without any under air, and then we send it for culture. So you can see the retina here, the disc here, the blood vessels. This patient had a choroidal abscess. We cleared it, and we normally have a tamponade called silicone oil, which we inject. So these membranes form into the in the vitreous. Something like when you do arthroscopy, you see these membranes. You can see the choroidal mounds here. This is a choroid which has infected. You can see the abscess here. The retina is intact. So at times, with a high risk, we have to go and even do a GA because the local anesthesia patient is uncooperative. As I mentioned, the most common is a hematogenous spread. Coming to the next, tuberculosis, we have been trying to classify the lesions of tuberculosis in the eye. The eye can be involved just with hematogenous like choroidal tuberculosis, which is infective, or you can have an immunological reaction. And sometimes the retinal pigment epithelium is known to harbor the antigen of the RP and mimics it. So we have a lot of uveitis, which is immunological, and you have to give steroids. So there have been attempts to classify TB and say that these lesions are more suggestive, and certain groups feel that even if the patient is Monto quantified positive with these lesions, we should give. There are 2 groups of people, and we are trying to create a consensus on what would be the ideal lesion for tuberculosis. At times, you don't find lesions. So there are certain lesions which we find in the eye we think are suggestive of tuberculosis. So we've created a consensus ocular tuberculosis study worldwide. I'm a member of that. So we have about 6 publications. We're trying to create consensus, though we may not have full data, because for endemic and non-endemic country, the criteria for diagnosis of TB may be different. So the patient can present as episcleritis, uveitis with synechia, or scleritis. or a retinal vasculitis. This is what a choroiditis looks like. It's a healed choroiditis which occurs as an immunological reaction. It's called serpiginous-like choroiditis, and it was defined by the PGI group. So where lesions looked like choroiditis, which is infective. This patient was a child who had these multiple tubercles, and the tubercles healed with scarring. So patient had 6S vision. On a routine checkup we found, and even after 12 months, the patient's certain tubercles didn't heal. So we suggested extension of the ATT for some more time. Sometimes the eye gives us a clue that TB is not fully healed. This is a patient who was admitted last week, presented at Gangaram. The patient was on 3 months of ATT second level and was not responding. This is a granuloma. So these granulomas are vascularized, and we have started giving anti-VEGF injections, Avastin, etc. So this is the other eye of the patient who came with a exudative detachment after giving moxifloxacin and Avastin, ranibizumab. The retinal detachment settled, and you can see the pigment epithelium of the retina damaged and the granuloma being clearly seen, which was not visible in the beginning. So the immunological problems are great in TB. Secondly, with HIV, you can see syphilis. We rarely see syphilis in isolation. Generally, we diagnose HIV or its patients a known case of HIV. So we get, this is one of the few areas where you get a good response to treatment and the vision does come back. So it can be a vasculitis. It can mimic every kind of uveitis. Choroiditis, this is a classical placoid lesion of syphilis, which responded to treatment. So this is one place where you respond. So the other infection like Bartonella can have a neuroretinitis with deposits in the macula and the disc edema. You can have rickettsial infections causing vasculitis. So viral infections can cause, plus these can also cause vasculitis. First, herpes zoster and simplex are one of the most sight-threatening. You can get corneal involvement like corneal ulcer in simplex and zoster. In dengue fever, we get vasculitis with even autovisceration. Every part of the eye can get involved with dengue. You can see the vasculitis here, the exudation blockage. Steroids might help. Chikungunya retinitis with the exudation of the retina. In dengue, chikungunya, you can have neuro-ophthalmological symptoms like optic neuritis, granular palsies, and a panophthalmitis also, if there's a ophthalmic artery occlusion. In herpes zoster, we all know that the nose is involved. The chance of an intraocular lesion is higher. Majority of the herpes zoster presents in these areas. So the eye involvement may not be in conjunction with the active infection. The uveitis, which is inflammatory, occurs about 2 to 6 weeks after the herpes has settled down. So it's important to remember that at 4 to 6 weeks, a checkup of vision is important because the uveitis might appear and patient may develop glaucoma. It is said that the herpes zoster resides in the Gisserian ganglion, but it also resides in the iris, and it can activate. So we have to give a combination of steroid with a cover of valsaclovir or acyclovir. And what happens? You have a corneal involvement, you have uveitis, and one of the classical features is that there is iris atrophy in herpes zoster. So we know when we see a patient of uveitis with this and with the increased pressure, and we sometimes have to give 1 to 2 years of treatment because it's a combination of immunological and infective. So we have to give long-term maintenance doses. It may also involve just the endothelium cells of the cornea, endothelitis, where you see they are disorganized and they become normal after treatment. There's another feature called frosted meningitis, where the vessels get distinct. It can be tuberculosis, it can be all viral infections, and can even be Behçet. So this is a very difficult clinical scenario for us. We need a PCR to diagnose, and here the vasculitis has resolved. You can have a retinal necrosis with herpes zoster and Gay's palsy, as I mentioned. Cytomegalovirus, you have a retinitis. If you remember, HIV before the heart treatment had much more eye infection, but you can have an idea, less than 500 CD4 count, you will have these infections, less than 250, pneumocystis toxo, and less than this. So we suggest all eye checkups for all patients of HIV. Herpes zoster is common, Kaposi sarcoma, molluscum contagiosum. Initially, you may have just soft exudate called HIV retinopathy, which requires no treatment. You may have cytomegalovirus. You may have to give a glycyclovir implant or injection. This is a patient of HIV with tuberculosis who on routine checkup was found to have a granuloma. They wanted to show how the granuloma heals. There's a pigmentation, devascularization, and it took almost 18 months for this granuloma to heal, which had no other symptoms in the eye. Parasitic, I'll just go through. Toxo is one. Now we have majority is acquired toxo. We have 2 lesions discard. So reactivation of the toxo lesion. Here's a patient who comes with choroiditis and again a new lesion after a few years. This is toxoplasmosis, for which you need to treat in conjunction with the physician. Toxocara is rare. We do find these granulomas rarely because in India toxocara testing is also difficult. Cysticercosis, you can have subretinal deposit, you can have intramuscular cyst, but this is one where you do not give albendazole because if this ruptures, you need to do vitreous surgery to remove the cyst subretinally. Malaria, we all know, can cause also. So almost all infections can cause uveitis. For us to differentiate between non-infectious infections, we need sometimes help of the infectious disease people. And there's a long list where the eye can be the presenting feature of systemic infection. Thank you so much.
Thank you, Dr. Amit. Vast topic, but very nicely covered. And you rightly mentioned in all HIV patients, we need to go for fundus evaluation because sometimes these hidden diseases like CMV, tuberculosis, we see in the fundus examination and is mentioned by the ophthalmologist. And then we can rightly screen in other sites of the body also. Thank you.
Thank you. Yeah. Yes.
You showed a slide of choroidal tuberculosis and treated for 12 months and then tuberculosis did not go away. So can that be taken because tuberculosis heals by scarring?
No.
Can that be taken as an indication to extend the anti-tuberculosis?
There's a controversy, but we suggest that we need to extend the treatment. Out of about 20 tuberculosis, 19 had healed, 1 didn't heal. So the patient had CNS tuberculosis also. Even in CNS, there's a controversy among the neurologists whether to give 12 months, 15 months, or 18 months. So if the tuberculosis is active, we suggest extension of the treatment. Thank you. Thank you so much.
Thank you, Dr. Ankita. Now I'd like to call upon Dr. Nemesh Mehta, liver transplant surgeon, Gangaram Hospital, and Dr. Anurag Gupta, senior consultant nephrology, Gangaram Hospital, to introduce the next session and speaker.
So we would like to invite Dr. V. Ramasubramaniam, who is a consultant, senior consultant for infectious disease and tropical medicine at Apollo Hospital. You have already heard about him a few minutes ago. So we now invite Dr. Subramaniam to enlighten us about pre-transplant workup and vaccination, please. Thank you, sir.
Thank you very much. Good morning to all of you. And over the next 20 minutes or so, I shall be talking to you about pre-transplant workup and vaccination. And after a hiatus of over 2 years, it is nice to be off Zoom meetings and see people in person. I had a very good evening last night, good camaraderie. So I hope we'll get back to this live soon. I don't have any conflict of interest. My talk today is going to cover 3 aspects. One is on the pre-transplant screening of both the donor and the recipient. 2, on the importance of vaccinations. And 3, the pre-surgical prophylaxis of patients who may be ending up with a transplant. If you look at the transplants in South Asia, the numbers are going up steadily. If you look at solid organ transplants, there were about 13,700 done in 2019. In South Asia, out of which almost 12,666 were from India. So India is a huge contributor to the number of transplants. Majority are kidney, and then we have some liver, heart, lung, and even pancreas thrown in. 83% of renal transplants were in living donors and 66% of liver transplant in living donors. If you look at the HSCT, over 75 centers in India doing over 2,000 procedures a year. There was a favorite statement of Abraham Lincoln of mine, who said that, give me 6 hours to chop down a tree and I will spend the first 4 sharpening the axe. So transplant is like that. Before you proceed to transplant, you need to have all your protocols in place. And this highlights the importance of the screening of donor and even the recipient. The pre-transplant workup is important because There could be people who have active infections, both in the donor or in the recipient, which may flare up after immunosuppression given for transplant. There could be latent infections, typically among the herpes viruses, herpes zoster, Epstein-Barr virus, cytomegalovirus. All of them may reactivate after the immune suppression. Recently, we are coming across the importance of colonization in the recipient population and probably in the donor population also. This may be related to multiple prior hospitalization, multiple exposure to broad spectrum agents, cystic fibrosis, or other conditions where there is a persistent colonization, usually due to drug-resistant bacteria. It could be cardiomyopathy with heart failure, which may again predispose to increased colonization, cirrhosis, and patients with organ dysfunction. So we are now looking not only at the usual screening, we are looking at changing our approach to ensure that the patients who are recipients are cleared of their infections and even colonization, and probably the donors are also adequately treated. And most importantly, vaccine preventable diseases. Unfortunately, this is still lacking in India. Vaccines are somehow not perceived as very important. And unfortunately, especially with hematopoietic stem cell transplant, there is not enough time to ensure that the recipient is vaccinated before the transplant is taken up. It is usually an emergency which leads to the transplant. The screening process starts with history taking. You need to cover all aspects of history, travel, animal exposures to cats, dogs, rodents, and birds, which is plenty in India. Dietary exposures. We recently had a patient with the brucella whose only history was that he was fond of taking pizza with feta cheese. Feta cheese is not a processed cheese, and it can lead to infections like brucella. Employment and hobbies, exposure to soil. My colleague Ram Gopalakrishnan is always away, several times in a month, lying on various grounds, looking at birds all over. So all this is important part of history taking. Potential to known exposure to tuberculosis, risk factors of STI, HIV, and hepatitis, presence of prosthetic material. This is often missed. Surgical history, drug history, alcohol use, and vaccination history. These are all should be part of the process of transplant workup. And unfortunately, apart from the large centers, this is not being adhered to seriously. The screening is mainly for the recipient, but as important for the donor also. Bacterial infections and treatment. It is now we are being a little more lenient. Even if a person who's a donor has died of, has been diagnosed of an infection, if the infection is adequately treated, at least 48 to 72 hours of treatment, when you think that the bacteremia has cleared, we clear the patient as a donor if he subsequently has brain death, but continue the recipient to treatment of the recipient to ensure that the infection does not flare up. Mycobacterium tuberculosis is a very important. There is a lot of controversy with regard to Mycobacterium tuberculosis. I was fortunate to be part of a guideline committee in India, and we have just come up with guidelines for solid organ transplant patients' approach with regard to infections, and that will be published in the Journal of Transplantation, I think this month or very soon. Viral infections, as I said, mainly herpes viruses, CMV, EBV, and then the hepatitis viruses B, C, A, and E, HIV, other arboviruses. All these need to be screened for before transplantation. We are also looking at parasitic infections, toxoplasma, strongyloidosis, and toxoplasma, which is conventionally considered as a problem with heart transplant, has been seen with other transplants also. And of course, malaria, leishmaniasis in endemic areas, and filariasis. This is a comprehensive table. This is the KDIGO guidelines for renal transplant, but the maximum information and evidence is available mainly for renal transplant patients. You see a whole host of screening, HIV, these are the tests, and if the transplant is delayed, you need to repeat it annually. So these are all very clearly defined. HTLV is not a problem in India. MMR is more for the donor. Non-viral infections like Staphylococcus, serology for strongyloidosis. This is now being considered an important part of transplant workup and treatment. Serology for strongyloids. Tuberculosis, a tuberculin test or an IGRA test is recommended, and annually if the ongoing risk of exposure is present. Now we need to understand that most of these guidelines come from the West, where TB is not in high prevalence as we see here. and their guidelines are different. So in the recent guidelines I was working on, our consensus, we modified that. I will tell you subsequently. Now, this is the guidelines. This is not yet in print. It will be coming out soon for specifically for South Asia, but mainly for India. So you will see HIV, CMV, EBV, hepatitis, SARS, HCV, strongyloides toxo, all of them are present. You'll see that Mycobacterium, it is mentioned only for history of TB in close context or inadequately treated TB. So the routine use of IGRA or tuberculin testing is not recommended. This is based on consensus and expert opinion from various people, both liver, kidney, and others. And of course, urine cultures for kidney and blood culture if there is a clinical necessity. This is the donor acceptance based on screening results. So these are for the donors. You could have a donor status, and then you take a call on the recipient status antibody and then take a recommendation. So if there is HIV positive in the donor, you reject the donor. If HBsAg is positive, but the recipient is HBs antibody titer surface antibody positive or his core antibody positive, some take up the organ. In renal or a non-liver organ, there is no problem. But if it is a liver which is being transplanted, then you need to ensure that the patient is treated or the antibody titer should be more than 100. SARS, HCV. So this is almost similar. This is being more clearly defined. This is again the Indian recommendation. This is for South Asia, which is coming out soon. There are also certain specific infections which are endemic to the South Asian region, which we need to look stress about. Tuberculosis, again, I said only for close contacts or people who have been inadequately treated. Melioidosis is a huge problem we are finding out, but then you look, if you suspect clinical disease, then you look for it. Histoplasma based on the urine antigen test, Penicillium marnophi, Sporothrix, Leishmania in high-risk areas, Bihar, Nepal, strongyloides, hepatitis E, and dengue if there is a peak season, because a lot of infections can be subclinical and outcomes can be poor in these patients who are transplanted. Now, stressing on latent TB, it is believed that 1/4 of the world population has latent TB. Almost 25% have a positive IGRA or a tuberculin test. If you look at India, that is as high as 1 in 2. And we know that there is a risk of TB activation usually following transplant due to immune suppression. In patients who have a positive MANTO or a TB IGRA test, the risk of activation is highest within the first 2 years. In India, it is very difficult to define when they seroconverted, because most of us here, I would feel, are positive, and we may have converted 10 years or 20 years before. So that is not a significant risk. So the rationale for doing or checking out for latent TB is that post-transplant, the risk of TB can be increased anywhere from 20 to 50-fold times. So that is the reason why it is advised. And the tests which are done, which is either the TB Gold, which is the IGRA, or the MANTO, are not either highly sensitive or specific. Both are very, very similar with regards to when they are positive, except that the IGRA has a slightly higher benefit in differentiating from BCG-induced positivity and the fact that non-tuberculous mycobacteria are not do not cause a positive test. But otherwise, these tests are not sensitive or specific. So the World Health Organization tells us that untreated TB, history of TB contact, recipients from donors with a history of untreated, these are all main reasons where you need to screen and test. But when we looked at customization for our population, as I said, all the experts strongly felt that in spite of the WHO recommendation, you don't need, because they don't do the test in most patients. The risk of TB in solid organ transplant is somewhere in the region of 6 to 12%. And if there is treatment of active TB in the recipient before transplant, the recipient has completed the intensive phase. Again, the recommendations are you need to complete the entire TB course before being taken up. But in India, we all feel that it is acceptable if they have finished the intensive phase. That is, if they finished 2 to 3 months and they are clinically responding, you can go ahead with the transplant. You don't need to wait for 10 to 12 months. Screening, again, both donor and recipient is indicated only in specific situations. A chest X-ray is recommended for all. If you suspect clinically there is tuberculosis, you need to work up. But routine MANTO or IGRA test is not indicated as part of pre-transplant workup. Chemoprophylaxis, either with rifampicin alone, rifampicin, which is for 4 months, rifampicin and isoniazid for 3 months, or isoniazid alone for 6 to 9 months can be given in situations, as I said, if the risk of activation may be high. This is our, this is a very practical, simplified our hospital approach. This is for the recipient: HIV, HBsAg, HCV, HBs titer, core antibody, TB furon, if there is no history of TB, TPHA, CMV. So this is a form which we fill. So if there is an infectious disease consult, which we have a standard, protocol of ID consult for all pre-transplant workup. So this is a simple form which we use. This is a recommendation regarding hepatitis C from the King's College, who are leaders of liver transplant. So now we have excellent modalities of therapy for HCV. So to simplify, if there is time for, for transplantation more than 6 months, which is 24 weeks, then treat them and then take them for transplant. If you don't have time, you can continue the treatment after transplant. These medicines are very effective, well tolerated, but you need to keep in mind the interactions with these directly acting antivirals. The second aspect is the vaccinations for solid organ transplant. These are all the vaccines. I won't go into the detail. I think these are all very clear now. There is no doubt with regard to the evidence. Pneumococcal, we follow conjugate vaccine, followed 2 months later by the polysaccharide vaccine. In India, I think still that is necessary. You cannot do away with the conjugate vaccine. Influenza, hepatitis B, hepatitis A, meningococcal, Haemophilus papilloma virus, Tdap, and COVID vaccines. And there is a specific risk which is very similar. This is for autologous hematopoietic stem cell transplant that was for solid organ. So this also is very elaborate, and this you can get in all the references are available. This is our recommendations for South Asia. That is very similar to most of what is available in the West. So if it is a planned transplant, take time to ensure that they get their vaccines to make sure that further infections can be prevented. A word on the live vaccines, which have to be avoided in post-transplant situation, mainly dengue, which is not yet available in India, the intranasal influenza vaccine, MMR vaccines, varicella vaccine, and yellow fever vaccine. The zoster vaccine is a live vaccine. It is not available. The newer vaccine, which is the recombinant vaccine from GSK, is likely to come by the end of this year, which is a 2-dose schedule. The Zostavax, which was from MSD, was a single dose live vaccine, which is no longer available. This is again our schedule in our hospital. We ensure, apart from COVID vaccine, the flu vaccine, pneumonia vaccine, Tdap, typhoid is done. Since our access to strongyloides antibody is limited, we treat all our patients with ivermectin prior to transplant. So 1 dose of ivermectin and sometimes repeat after 2 weeks, we routinely do. These are all practical approaches in a resource-restrained and time-restrained situation as in India. A word on COVID, I think it's very clear. Donor screening is done. Vaccination now, everybody before, either donor or recipient is strongly advised. Recipient screening is done. In our guidelines, we have said that wait 3 months. I think there is a lot of information coming up now that it is, even if the patient is perfectly fine, doing a transplant in 4 weeks actually results in poorer outcomes. So you have to wait 3 months if you're going to be clear that outcomes are going to be good. And of course, there are several situations which may compromise this is for COVID vaccine, but this may be extrapolated to other vaccines also. We have realized use of agents like rituximab may impair your immunity for up to a year, 6 months to a year. So you need to keep that in mind, especially when you give vaccines. So that is why it is very important that vaccines are given before treatment is started. You can postpone treatment by 2 weeks, if possible 4 weeks, and finish all your vaccines. Lastly, surgical prophylaxis. SSI, surgical site infections, are the most common hospital-acquired infections, varying anywhere from 3 to 50%. It increases mortality, morbidity, cost of hospitalization can increase by 100%, length of stay by almost 7 days, increases the risk of readmission and graft failure. And somehow organ transplant patients are at a uniquely high risk. There is also recently a high prevalence of MDROs in the surgical site infections. And to compound the fact, there is scarce formal guidelines. So please remember, the surgical antimicrobial prophylaxis, the goal is to ensure that you limit the occurrence of SSIs. You are not giving antibiotics to prevent ventilator-associated pneumonia, other infections in the patient. You are only focusing on preventing a surgical site infection. This is a paper which I came across about 3-4 years ago. which came up with some guidelines and showed that the highest risk of SSI was when intestinal or visceral transplant, anywhere from 15 to 53%, going up to 100% if the mesh is used. Second is pancreas and pancreas plus kidney, about 9 to 45%, liver 10 to 37%. Kidney is low, only 3 to 11% of infection. And these are the various organisms which cause it. And as I said, we are now coming across increased prevalence of infections due to multi-drug resistance, carbapenem resistance, and even colistin resistance. So the guidelines for what antibiotic to use is very, very varied. I have done a sort of impromptu survey in various hospitals and liver transplant units, and all of them have anywhere varying from piperacillin and tazobactam as prophylaxis to colistin as prophylaxis. And that goes on, not, you know that there is no role for extending surgical site prophylaxis beyond 24 hours. I find they give 5 to 7 days of prophylaxis. So there is still no consensus. It is a very, very sensitive issue, which people take personally. So when we discuss about antibiotics, the surgeon is very, very, with due apologies to the chair, surgeons are very, very, sensitive about antibiotic. No, in India with resistance, this is what we give. So I don't have an answer, but even in the West, they are now cognizant of the fact that we have to change the prophylaxis. If it has been shown that if a person is colonized by a highly drug-resistant bacteria, his risk of infection increases. But it is still not clear. There is no evidence to say by using an antibiotic which covers that, you can minimize the chances of infection. So that is still not yet clarified. But for non-transplant, that is becoming more popular. So I expect in transplant also it will change. So the choice will change to cover resistant bugs. These are patients who are frequently in and out of hospital. So we may look at tigecycline or colistin, but the question is how long? Because it's been very clearly shown that the longer you use an antibiotic, the greater the risk. So you give one dose, is that adequate? You saw in the previous slide that redosing has to be done during operation if twice the half-life of the antibiotic use, the surgery extends beyond that. So redosing is clear, but what about post-operative dosing? Most of them, it is, the dose is there, but how much is the question. So the other question is on the role of antifungals. It has been shown, for example, if you take lung transplant, the risk of infection is very high. So you may need to continue prophylaxis for sometimes a week or even 14 days, especially in cystic fibrosis patients. So there's still no clarity among them, but we definitely know the collateral damage of using broad spectrum antibiotics in a prolonged fashion. So we have to balance out the benefits of broad spectrum antibiotic as prophylaxis with the risk of what collateral damage may happen. Just a word on the specific reasons, typically antifungal, I'm not talking about hematopoietic stem cell transplant, that is well defined, but for solid organ in liver, this is the specific, the highest risk for, candida is mainly for pancreas and liver. So specifically with liver, if you find, prolonged surgery, prolonged intensive care unit, reoperation, you need to use antifungals. But again, the question is how long? Is it 48 hours? Is it 72 hours? I don't think we know. Lastly, I found this recently, eradication of incurable sadness. So I think I envy people in Goa who have access to this medicine, but in a lighter note. But I think, as I said in the beginning, the most important aspect of approach to a transplant patient is plan and screen and have a protocol in place, which could be unique to your setup. What I do may not be relevant to you. So create your own protocols, but try to limit antibiotics as much as possible. Of course, vaccines are important and pre-transplant surveillance is important. Thank you.
Excellent talk, sir. You have beautifully set the guidelines regarding pre-screening of the infectious disease. But because of the limited resources, it is not easy to screen HSV. It is not easy to screen for strongyloidosis. What we follow at our center is just to screen the viral markers, CMV and Epstein-Barr virus. We find strongyloidosis very rarely in 1 or 2 cases. Second thing is chemoprophylaxis with arsen. The arsen is an enzyme inducer, so we will be more happy with the INH for 9 months. And Third thing is vaccines. If we want to give live attenuated vaccine prior to transplant, they should be finished at least 8 to 12 weeks prior to transplant. And if post-transplant live vaccines cannot be given as you told, and even we want to give any vaccine post-transplant, that should be 3 to 6 months after the transplant once the immunosuppression is low.
I think all points well taken. Live vaccine, I think at least 4 weeks before is fine. I don't think we need to wait 12 weeks, but 4 weeks is good enough. I agree to the fact that, doing all these tests is very difficult. That's why I showed you our Apollo protocol. Even though Apollo is supposed to be a little elitist, still we do a basic few. And I think that's what I said, you need to customize to ensure. And 3, for stronger loiditis, because the impact can be severe, the mortality can be anywhere from 10 to 90%. That is why giving 1 dose of ivermectin is probably a little more practical than. Thank you.
We have a question. Please go ahead.
If tuberculosis is so prevalent as to have 1 in 2 individuals as adults of tuberculosis being MAN2 positive, and these days with a short-term anti-TB 3-month course of INH and rifampicin available for latent tuberculosis, why shouldn't we give prophylactic treatment to patients who have a positive MAN2?
Right. 2-3 questions. 1, the MAN2 test is highly error prone, both MAN2 and IGRA. It has a significant, huge lacunae in both sensitivity and specificity. So depending on the test to decide whether, if it is a positive test, yes, it has some value, but a negative test has no value. 2, rifampicin is not available for commercial use. It's been shown in studies that a shorter course is acceptable, but it is not yet available freely in India. 3, the impact, in general, the prophylaxis is based on the impact. For example, in the general rule of thumb is, if a disease is likely to be seen, at least 10%, but minimum of 5% in a population at risk, you give them prophylaxis. So the hematopoietic stem cell transplant patients received automatically, antifungal prophylaxis if the risk is high. If that risk is perceived to be lower, which is what most Indian transplant surgeons and physicians feel, it is 5 to 10% in the best of studies, and that too based on all our error-prone diagnostics. So it is not worth subjecting. You might as well wait, diagnose, screen, and then treat them. It is acceptable because our approach or our familiarity with tuberculosis is very good. We are not too worried about handling tuberculosis. That's the reason.
Can I add? Is now available in India. In fact, the National Tuberculosis Control Program recommends rifampicin and
it is available. It is available in the government side, but not in for the private side. At least I have not had access to rifampicin.
Yeah. So can I also add to your tuberculosis? In fact, we have done transplant for drug-induced post-ATT liver failures. So in general, also just to treat them as a prophylaxis and give them ATT may not be a good idea. So
I think that's what most experts felt, that the risk of the medicines is actually much higher, and it is better.
Because what happens in the general population is many times patients go with some fever, low-grade fever. This is non-transplant setting, but low-grade fever, cough, X-ray chest may not have major finding changes. And just because TB is so prevalent in India, the general physician will treat them with antituberculous therapy. And then we get, after 2 months or 2.5 months later, we get patients who have come to us with liver failure requiring liver transplant for ATT. So when the prevalence is not so much, we understand that tuberculosis is there, but the incidence, what we see even post-transplant, is not very high. And in the general public also, when we have a higher incidence of post-ATT liver failure, it should be used with a little bit of caution. Ma'am has a question behind, please.
My question is about
it is recommended by most guidelines, but as I said, that is something which is probably a low priority rather than high priority.
In our transplant, we are giving vaccine only for hepatitis B and this pneumococcal influenza and varicella 8 weeks prior to the transplant. These mainly 4 vaccines we are giving.
I repeat, there is still not much clarity, but we are now leaning towards But inevitably, you will find carbapenem-resistant organisms in them. But the question is whether the choice of antibiotic for surgical prophylaxis is going to impact and create better outcomes. We are still not clear. So that's something to. Agreed. I perfectly agree. But to tell you the truth, most transplant institutes, people who do transplants will agree, they do use polymyxins. Agreed.
One of the reason I'll jump in here as well. One of the reason why we are so skeptical about is most of the post-transplant patients, the mortality is due to sepsis. And we try and follow and emulate the Western world. But if you look at their infection rate, it is much lesser than our infection rate. The asepsis protocol is also hugely different. And the third point is that in post-transplant recipient, they generally don't give you that much window to have a culture positive and then change your antibiotics. I personally feel that by the time you have actually lost the game, when you have actually got the culture report back, it takes about 3 days, 4 days time to get your culture report back. You may, in certain cases, would have lost the game. So it is better to err on the side of giving the antibiotics initially, and whenever you feel, you downgrade or downstage and then come down on the antibiotics. So I agree with him that we as surgeons are very, very skeptical, but these are the reasons behind why the skepticism is there.
Thank you, sir, for this enlightening session about the pre-transplant workup. So now we are moving forward towards tea break. I insist that you can get your tea here, so because we are running short of time, and so that we can continue our session.
So we move on to the next session. And while we are investigating a patient, radiology is one of the first few investigations which we order after the blood test. And it's like a mirror to the patient per se. To discuss ID radiology, we have Dr. Rajeev Soman sir. Dr. Rajeev Soman sir is my mentor, and he has shaped my life as well as life of so many physicians who have now trained infectious diseases. Currently, Dr. Soman is he's the chief of infectious diseases in Jupiter Hospital, Pune, and he is one of the executive members of CIDS and also heading the HIV subcommittee. At the same time, he has also written several case books in infectious diseases, which includes a case book in COVID-19, case book in HIV, case book in infectious diseases as well. And he also runs infectious diseases fellowship in Jupiter. He's also visiting consultant in Hinduja Hospital even now. With this brief introduction of the vast work Dr. Soman has done, we will move on to his session on ID radiology. And to moderate this, I request Dr. Salesh Sahai. Sir is a senior physician in Max Hospital, Gurgaon, and I'll request him to moderate the session, please.
Thank you, Dr. Neha. I invite Dr. Rajeev to this desk. It's online.
Hello, friends. It's indeed a great pleasure to participate in your meeting. My thanks to Neha and everybody else from Delhi. I'm going to speak to you on radiology of infectious disease. So my disclosures, friends, I'm not a radiologist. I don't have the flair to stir you or to restrict and weigh you down with diffusion, discuss centrilocular or random distribution of modules, but my business is to provide a tidy explanation for the clinical and radiologic findings to ultimately try and get a microbiological diagnosis. And radiology, of course, is a science of images, and there are so many different things which use almost the same type of image that it is very difficult to have a full diagnosis only on the basis of radiology. Radiology actually helps to generate a differential diagnosis. Diagnostic radiology gives us the nature, the size, shape, number of lesions in order to generate a differential diagnosis. But usually we do not get a specific or a microbiological diagnosis. What the clinician additionally needs is to know what is the etiologic organism, what might be its susceptibility. Is this lesion active, inactive? Is it a chronic lesion? Is it an acute lesion? Or is it really a paradoxical response? Interventional radiology does give us some more information. Gives us the specimen for you to biopsy. But let me tell you that every abscess, so-called abscess, should be biopsied, and so-called tumor should be cultured. So how can we hope to get a microbiological diagnosis by culture? So let's take this first case. So this is a kind of relapsed with myeloid leukemia, just this case. The fever and cough started. Just and her adjustment was done 2 days later. It shows you these nodules. There's also reported lesions. You can see lots of nodules along with yellow signs. And And on this basis, voriconazole was started. Some further tests were done 4 days later. In these tests, the patient was referred for an infectious disease opinion. So the blood culture peripheral collection had grown streptococcal species. The Aspergillus galactomannan, which was obtained 4 days after starting voriconazole, was negative. And the biofire respiratory panel showed nothing else was positive except human rhinovirus or enterovirus. So the question in front of the ID physician is, what is the likely cause of this problem? Is it due to the Viridans group streptococcus? Is it still Aspergillus? Or is it rhinovirus, which is not? So if you look at each one of these differential diagnoses, Viridans group strep is not likely to be this type of unless there is a hematogenous spread from an infected endocarditis generally involving the right side of the heart. Aspergillus certainly is still possible even if the galactomannan is negative, as the test has been done 4 days after starting voriconazole, which can really influence the positivity of the test. What about rhinovirus? Rhinovirus was detected by molecular diagnostics with this biofire test, but the causal association with this kind of pneumonia and the rhinovirus is very, very, very uncertain. The mucor may be suspected in because of some of these points, but generally it tends to produce a large number of nodules. There's a prominent mediastinal and pleural involvement, and sometimes a reverse halo sign. All these have been absent in this test. So the patient did respond to voriconazole, but fever recurred along with the recovery of Mycobacterium. So whenever this happens, the clinician should be alerted to the possibility of hepatosplenic and renal candidiasis. So imaging of this abdomen was done, and as you can see, there are these lesions which are there in the spleen as well as in the kidney, as you can see here. So all this indicates deep-seated candidiasis, which has developed because of seeding during the phase of leukopenia. And once there is a recovery of leukopenia, there can be an inflammatory response, like a paradoxical response, which tends to produce fever. Now, how would you get this diagnosis? It is really difficult at this stage because blood culture as well as biopsy are unlikely to give you a specific pathogen. Possibly a beta-glucan done from the serum is likely to be positive here. And it's important to remember that this is developing even while the patient is on voriconazole, which indicates the paradoxical nature of this particular, so like an immune inflammatory syndrome. And sometimes some patients do need a little bit of steroids in order to take care of that fever. So you could actually get a microbiological diagnosis by imaging of aspergillosis as well as deep-seated candidiasis in this particular patient. Now let's take this second patient. So how can you get that diagnosis? So this is the lady who had an ITP, who's on steroids and azathioprine. She's not on PMP-SMX, that is factoring, or not on INH. The platelets are very, very low. There is headache for a month, and over a period of 12 hours, right hemiparesis developed. The CVS was normal. A single brain lesion was seen with marks around the edema, as you can see this. The biopsy is contemplated, but just not affording IVIG to try and raise the platelet count, so it was impossible to do a biopsy. So is there any scope in which, any way in which radiology can help us? So probably yes, MR spectroscopy can be useful. Although let me remind you that all radiologists do not agree on the particular usefulness of this particular test. So MR spectroscopy was done in this case, which did show a large lipid peak and also a relatively smaller but lactate peak. Now, when you have a very large lipid peak and a relatively smaller lactate peak, it is highly suggestive of tuberculosis. And when it is the other way around, where the lactate peak is much higher, it is more suggestive of a brain abscess. It could be toxoplasmosis, it could be bacterial brain abscess, and so on. So in this way, we could get a reasonable certainty that this could be tuberculoma, and the patient was started on antibiotics. Now in this patient, she was a lady with diabetes. There was fever, excruciating pain in the neck, which was going on for about 15 days. There was no cough at all. She was treated elsewhere with levofloxacin for 10 days. There was no improvement. By now, she started developing right lower limb weakness And as you can see, there is a lesion in the spine over here with spinal cord compression. So she presented to us with a high WBC count with creatinine of 3, urine showed pyuria, although the culture in the urine was negative. So this was the imaging which showed this particular lesion, which looks like a pleural effusion on this side. Maybe some infiltrates are also there. And this is the transverse section, which actually which shows this abscess with these air pockets over here in the neck. So what do you think could be the etiology of the vertebral abscess? Could it be TB? Could it be Staphylococcus? Could it be Pseudomonas? Could it be E. coli or Klebsiella? Okay, so if you really see these air pockets, tell you that this must be an infection with a gas producing organism. So neither TB nor Staph aureus nor Pseudomonas are gas producing. And therefore it is much more likely that it is due to E. coli or Klebsiella. And we've seen this often, that spinal abscesses do occur due to organisms which are coming from the urinary tract. So there was no way to start treatment on this without a CT guided biopsy. And the CT guided biopsy confirmed that this is a pyogenic vertebral osteomyelitis, and E. coli was found in this particular biopsy, and the patient was treated. The sputum also was done, which showed actually TB, which was pan susceptible, and the patient was placed under appropriate treatment. So you have this patient who has a pyogenic abscess in the spine as well as pulmonary TB. So usually we are taught to make a single unifying diagnosis, a single etiology to explain both the things. But let me remind you that that may not always happen. And so the clinician must not be trapped by this principle of parsimony and must try to obtain biopsy, because otherwise it would have been wrong to just put this patient only on anti-TB treatment. Now radiology also helps us with specific localization. And let's take the example of this case, who was a patient on maintenance hemodialysis for chronic kidney disease. The patient presented with fever during dialysis, also developed an acute stroke, and had positive blood cultures. So this was from the peripheral culture, which showed Pseudomonas, as well as from the HD catheter line, which showed Pseudomonas as well as Introbacter. Now imaging showed that there are two acute infarcts in two vascular territories. So you have this vascular territory, which is clearly the middle cerebellum, as well as the posterior circulation. So you have an infarct in the cerebellum as well as in the middle cerebral artery territory. As well as if you see here, there is a thromboembolism in this artery. So all this is telling you that it's not only one side, it is in both sides, as well as three different vascular territories. So this indicates that this is coming from the heart. So this indicates a cardioembolic source. So likely there is an infective endocarditis. And since the transthoracic echo was negative, transesophageal echo may help us and is absolutely a must. So in the transesophageal echo, what was seen was a thrombus was attached to the permacath, and therefore a patent foramen ovale was suspected, and that was confirmed. As you can see, these are the gas bubbles, which was confirmed on contrast echocardiography. So this radiology really helped us with the MRI in the brain, telling you that three vascular territories are important. It also helped us by finding this thrombus which was attached to the permacath, and also gave us an answer like why so many systemic vascular embolization episodes have occurred because of the patent foramen ovale. Another case which helps, where radiology helped to localize the lesion. So this is the patient who had a right renal angioplasty. Stenting was done. Also had a large aortic aneurysm for which stenting was done. So you have a large stent in the descending thoracic aorta aneurysm, as well as the TCA, which was done for the right renal artery. So the patient presented 2 months later with persistent fever. So the PET scan was done, which actually told us that this is the particular thing which is lighting up. If you notice, the aortic stent in the descending aorta is not lighting up, but what is lighting up is the stent in the right renal artery. The blood culture grew non-tuberculous mycobacteria rapidly growing, so it was actually Mycobacterium abscesses. And so we actually advised resection or excision of the renal artery with that stent and auto transplantation of this right kidney. If it was done in time, perhaps it could have saved a lot of further problems which this patient had. So this PET scan actually told us where is the infection in this tent, not in this tent. Okay, so we could probably take a good plan out what can be done next for the patient. Certainly, diagnostic radiology helps in the generation of differential diagnosis, and let's take this case where how the radiology would help. So this is a diabetic patient presented elsewhere with fever, cough, and leukocytosis. And this was, as you can see, two large abscesses with very shaggy walls. And the sputum culture which was done showed a rich growth of E. coli as well as Candida species. So the patient was treated elsewhere with pip-tazo for 4 days, but the patient did not respond, so was changed to colistin and fluconazole after seeing this report. Unfortunately, the patient kept on worsening, which would be somewhat expected in this situation. And then he presented to us. He was found to have these lesions on his ankle, so there was a septic arthritis with the discharging sinus from the knee, as well as dactylitis. Now, on exact inquiry, this patient was an alcohol user, who's a paddy farmer from New Mumbai. So, what do you think would be the lack of response for this patient? And obviously, this is not because of that E. coli or fluconazole or Candida, for example. So this patient had a cap with a community-acquired pneumonia with a cavitating infiltrate, and the collection of this showed Burkholderia. This was the blood culture which showed Burkholderia pseudomali, which is the agent of melioidosis. So what gave us the diagnosis was this is a spatial epidemiology. The patient had clinical features as well as lack of response to colistin. All this points to the etiological diagnosis of melioidosis, which can produce this kind of large lung abscesses. The patient was successfully treated with meropenem and DMT-SNX after the diagnosis was made. So one can have a diagnostic algorithm for pulmonary infections depending on the type of infiltrate. So if you have a cavitating infiltrate, it is these organisms which we should keep in mind. And then you have various other different types of infiltrates with specific organisms for each. You can also refine the algorithm further based on the critical signs and symptoms, acuteness of the process, degree of hypoxemia, and epidemiological clues. So you need a lot of other inputs from clinical medicine, history, examination, and certain other investigations to refine the algorithm which can be generated by radiology. Radiology also helps us to have an image-directed biopsy. For example, in this patient who was given a diagnosis of SID, was on steroids and mycophenolate, developed fever, cough. There was no response to antibiotics. A chest CT was done. The patient took ATT based on this findings. Here, the patient had some kind of an infiltrate on both sides. The patient developed seizures and headache. His antitoxo IgG was positive. This patient was reluctant to undergo further tests. He required lots of convincing for at least to do an MRI brain because he had developed seizures and headache. And here you find several large lesions which are multilocular with surrounding edema and so on, which are distributed in various different parts of the brain. So what do you think may be likely here? Could it be MDR-TB because this has developed while the patient is on ATP? Or could it be toxoplasmosis, or could it be aspergillus, or we still cannot see? And the answer, I think you will agree with me, is that we still cannot say without a brain biopsy. Sometimes we do have to do a lot more tests in order to arrive at the diagnosis. And sometimes the patient is a very difficult patient, and the diagnosis is also very difficult, which can only be achieved with a biopsy. And so finally, he agreed for a stereotactic biopsy, and what you find here are the beaded branching delicate filaments of nocardia, which was confirmed on culture. So this would not have been diagnosed without the brain biopsy, which is very, very important. And antitoxo IgG being positive, but the neuroradiology not particularly correlating with toxoplasma in a non-HIV patient is definitely not highly suggestive of toxo. It does not merit a therapeutic trial with antitoxo treatment in this group of patients, and we definitely need to proceed with a brain biopsy. Finally, sometimes the imaging diagnosis is there, but you need a back correction of the imaging diagnosis. And let's look at this case who had a 22-year-old male patient who had a high-grade tibial osteosarcoma and had a large megaprosthesis there after his surgery. The patient received 9 cycles of chemotherapy through a port. He developed an abrupt onset high-grade fever, but there was no respiratory symptoms like cough or sputum. He had severe neutropenia with an absolute neutrophil count of only 186. He was treated empirically with meropenem, and a CT scan was done. As you can see, there is this port here, and a CT scan showed these nodules again with surrounding halos, which were reported as consistent with invasive pulmonary aspergillosis. So the patient was started on voriconazole by the hemat team. The blood culture grew methicillin susceptible staph aureus. So the meropenem was continued, and the next blood culture after 2 days was negative. So meropenem was given for a total of 7 days, and the patient was discharged. Remember here that the serum galactomannan was negative at that stage. Now, a month later, the patient developed pain and swelling in the knee where the megaprosthesis was there along with fever. So they did a knee aspirate, which was found to be turbid. The culture of that aspirate was awaited, and meanwhile, the patient was referred for an ID opinion for suspected aspergillosis of the knee. So if you re-examine the diagnosis of invasive pulmonary aspergillosis a month or 1.5 months earlier, it really appears unlikely. Now, why do I say that? Because there was an abrupt onset of fever without cough or other respiratory symptoms. The serum galactomannan was negative while the patient was neutropenic. Remember that the sensitivity of serum galactomannan is close to 90-95% in a patient who has severe neutropenia. And the patient was not on mold active prophylaxis. So he really had no business to have a negative serum galactomannan if it was really aspergillosis. And what about aspergillosis of the knees? We think it's quite an uncommon problem. So what could it be? So remember here that a patient had a chemotherapy board in place for several months, which could have actually produced the MSSA or Staph aureus bacteria. The patient had an abrupt onset of fever during that initial illness when the Staph aureus bacteremia was found. Now, while nodules with halo are certainly characteristic of invasive pulmonary aspergillosis, the same appearance can occur due to many other causes, such as abscesses due to Staph aureus. So this could certainly have been hematogenous lung abscesses due to Staph aureus. So since he had received meropenem only for 7 days, which is in any case not the preferred drug for Staph aureus bacteremia, and the infected port was not removed, it was still in situ, it is conceivable that seeding of that megaprosthesis could easily have occurred, resulting in staph septic arthritis of the knee with the prosthetic infection. This seems to be the most likely scenario and the diagnosis. Therefore, accepting the imaging diagnosis of invasive pulmonary aspergillosis, which was just written as a compatible with this particular diagnosis, led to the erroneous treatment. It also led to ignoring the correct approach to Staph aureus bacteria. So this was the blood culture as well as the right knee periprosthetic fluid, and this was showing the same Staph aureus, methicillin susceptible Staph aureus. So the port was removed, and the metastatic infection due to the Staph aureus bacteremia and the metastatic infection. Ideally, removal of all this hardware is really needed. However, it will have a lot of practical difficulties in trying to remove the megaprosthesis. So the patient was given oral chronic suppressive therapy for some time. So I'll conclude by saying that imaging is certainly very, very useful, and imaging has really advanced. We have so many things now. We have various different types of MRs, CT scans, PET scans, echocardiography, so many others. So it's really advanced to the point of being absolutely realistic. Okay, to the point that sometimes the physicians get sold on the diagnosis which is being offered by the radiology. Really makes his mouth water, and so to say, run away with that diagnosis. But I'll pause here and say that radiology will offer a differential diagnosis. And after that, you need a lot of microbiological and clinical correlation is needed in order to make a final diagnosis. And with this, I will stop. And if there are some questions, I'll be very happy to try and answer them. Stop my speech and I'll turn it over back to the organizers. Thank you.
Excellent talk, sir. Any questions? Questions from the audience?
Histopathological as well as microbiological examination, because medicine is a specialty where there are always surprises. So sometimes we tend to treat on the basis of images, especially neuroimages, as he rightly saw that case where no cardia was shown. So we would not have been able to diagnose that without a biopsy. Sometimes we as clinicians also get chicken hearted as to why go for a biopsy when the picture is like that. So it is very important for especially my junior colleagues here, that we should try to get microbiological as well as tissue diagnosis where possible.
And absolutely. And at the same time, history is the most crucial as well. A lot of times you will have diagnosis as tuberculosis if you have vertebral osteomyelitis, but go back to the history and see what has been the onset, duration, and progression. And you will we all are surprised when we see pyogenic instead of TB, or we see a fungal infection instead of that. So as sir has put it, microbiological, radiological, and clinical correlation is extremely important.
Thank you, sir. So the next session, next talk is CROI 2022 update by Dr. Atul Kakkar, sir. And to chair the session, I'd like to invite Dr. Sunita.
Ma'am is actually, she has to catch a flight. So Dr. V.R. Subramanian, sir, will be chairing the session.
This session is, the speaker will be Dr. Atul Kakkar. Yes. And I think I don't need to introduce Dr. Kakkar in this to this audience, and he should give us an update on the CROI 2022.
Thanks so much, Dr. Subramaniam. And indeed, it is an honor to be presenting with stalwarts. Just having presented prior to me, it's great to be presenting here. Actually, CROI 2022, some of the junior colleagues may not know, it's a conference of retroviral and opportunistic infections, which is our annual conference, which was recently held in February. So it is a big conference. There are a lot of new studies coming in. So I would just like to, I'll just like to show you. This was the kind of conference it was. It was a huge conference with more than 1,500 accepted abstracts and 38 accepted late breaker abstracts. So it's a big conference. We will not be able to cover the whole thing, but we are just going to cover a few studies which are related in HIV management and which may practically help us in our day-to-day practice. So I'll try to finish in 15 minutes. It's going to be a little difficult, but I'll try to do that. So this is just a slide from the WHO guidelines. And this slide shows you the upfront first-line treatment, second-line regimen, which we follow. That is 2 NRTIs plus DTG. And the second-line regimen is 2 NRTIs plus a PI, that is an atazanavir or 2 NRTIs plus darunavir, boosted darunavir. So that is what the current understanding for the first line and the second line is for the adults and adolescents. So relating to this, how our management and thinking about second line management is, and so for this, there is a nice study which was discussed at this meeting, which is the Vicent study, which had a comparison between the PI-based ART plus a DTG-based ART regimen for second-line therapy. So as convention, we have been using a PI-based therapy for second-line till recent times. And this is a study design, which was a randomized open-label non-inferiority phase 3 trial, which was done in Zambia, in which they had 2 arms. And they were patients who were HIV positive on efavirenz or nevirapine plus 3-TC TDF. So close to 1,200 patients. Arm A, there was less than 1,000 copies, and Arm B was more than 1,000 copies. And they were randomized into different groups. The one which was virally suppressed, that is less than 1,000, was DTG plus 3-TC TDF, and the other one was DTG plus FTC and TAF. So that was more than 200 patients in each arm. Whereas in Arm B, if you see, where the viral load was more than 1,000, there also the randomization was DTG, again with 3-TC TDF and FTC TAF, along with the PI, whether it was lopinavir or atazanavir, in combination with 3-TC and AZT, similarly 3-TC AZT with both the things. And what the intention to treat was, the primary endpoint they were looking for was a viral load of less than 1,000 at week 144. And the current analysis which was presented was at 48 weeks. And what they found out was that if you see the response to treatment, if you see whether it was less than 1,000 copies or more than 1,000 copies, in the DTG plus 3-TC TDF was non-inferior to DTG plus FTC and TAF, regardless of whether the viral load was less than 1,000 or more than 1,000. So it was a comparative whether you use 3-TC or FTC TDF TAF. And again, the DTG plus 3-TC TDF and the DTG plus FTC TAF combination was superior as combined to the PI arm. If you see both the arms, it was superior in the DTG arm was superior. So that is where the thing was. And the only concern which all of us has been seeing is the weight gain. So the weight gain change was looked up at 48 weeks, and as expected, the weight gain was more in the DTG and the TAF group the most, whereas it was less in the other arms. If you see the overall weight gain, 2.8, 1.15, 5.4. So as you are seeing the DTG TDF or the DTG TAF, that is the where, and especially when the viral load was high, the weight gain was more, and weight gain was slightly more in women as compared to men. So that was the first study. The other study which was discussed was the Nadia study. Again, this was a study, it was a multicentric 2x2 randomized open label non-inferiority phase 3 trial in which they looked at DTG plus boosted darunavir and TDF vis-a-vis AZT for the second line therapy. Again, randomization into 2 groups. The patients were receiving TDF plus 3-TC FTC plus an NRRTI for more than or equal to 6 months with treatment failure by way of viral load of more than 1,000. And DTG, one arm was given DTG 50 milligrams, and the other arm received boosted darunavir. And it was the DTD group was further randomized with 2 groups, that is 3-TC TDF and 3-TC AZT. And again, the boosted darunavir also had a similar backbone arm, and they were followed up for 96 weeks. The primary aim was to study the non-inferiority of DTG to boosted darunavir and of 3-TC TDF to 3-TC zidovudine in the second line. And the primary endpoint was they were looking at RNA of less than 400 copies at week 96. And at 48, they found at 48 weeks was that DTG was non-inferior to the boosted darunavir, although there were 4 cases of DTG resistance, and 3-TC TDF was found to be non-inferior to 3-TC AZT. So this was again something which was heartening to see that this was comparable. And if you see as week 96, the efficacy, if you see the HIV RNA levels less than 400, DTG and the darunavir group is comparable. The more than 400 viral load, again, there were less in that group. We drew because of adverse effect. There was nothing much to say about that. And if you see the RNA load of 1,000 in the DTG group, there were 213. So it was very comparable. It was no statistical difference if you see across the various groups. this was another subgroup analysis in which they found out whether the patient, whether they were receiving tenofovir or azithromycin. If you see the first bar on the top there, if you see the tenofovir was there and azithromycin was there. If you see the comparison between dolutegravir plus darunavir boosted is comparable. If you see dolutegravir, when the backbone was, there was azithromycin, there was a slight less response with the darunavir, and the number of predictive active, it is comparable in the two groups as far as the active NRTIs are concerned. So further going on to the backbone of the resistance, where there was baseline resistance was present or absent. If you see where the baseline resistance was present, this is the where at baseline tenofovir, azithromycin, if you see the response was much better with the tenofovir arm vis-a-vis. But if you see the resistance is present at baseline, still the response was there. So it is like you can still use, tenofovir when you have a first line failure, because even with K65R, you could have a good response, that is 95.7, although it was comparable to zidovudine, not statistically different, but still the response was very good. And if you see with the other baseline resistance, again, here tenofovir, the resistance is not there to the MI184. The response is statistically significant and much better with tenofovir vis-a-vis AZT. Even when the baseline is present, the gene is there, the comparable response is there, still tenofovir is working. So this is what, even beside having some amount of resistance there and baseline gene there, still tenofovir can be recycled and used for. So what was the key take-home points from these studies for the second line therapy? That people who are failing first line with an NRTI 3TC TDF, in the recent trial, we could see that DTG plus 3TC TDF was non-inferior to DTG plus FTC TAF, and both DTG regimens were superior to the PI-based regimens, whether it was a lopinavir-based or atazanavir-based, and weight gain, as we saw, was greater among women, especially with a combination of DTG TAF. And those who are failing on an NRTI AZT TDF, as was seen in the Nadia trial, the DTG plus 2 NRTI was non-inferior to boosted darunavir, and TDF was found to be superior to AZT. So the other new concept is the two-drug ART for switch. So there is a lot of discussion on this, a two-drug ART for switch. Why we want to do? Because we are seeing as more and more side effects are there, we want to do away with TDF. So things like that. So this was the SALSA trial, in which they found that multi-center randomized open label non-inferiority study, in which they switched to TDF, they switched to DTG plus 3TC, and continued the other group continued the 3-drug ART. I'm not going to go in detail because of want of time. I'll just skip this, and I would just want to show the conclusion here that using the stringent criteria of viral load of less than 40 and TND, proportion of patients even with archived resistance who responded at week 48 was similar with the switch therapy of DTG 3TC as was continued, those who were continued on 3-drug ART. And this data was combined with prior results and supported the use of DTG 3TC as a switch strategy in virologically suppressed. So it's very important they have to be virologically suppressed, not to be used upfront. That is what it is. Just a quick word about a negative study, comorbidities and co-infections. We see a whole lot of comorbidities as we are seeing more and more HIV patients are living longer and they have other comorbid illnesses. So there was this trial in which they wanted to see whether ART intensification and the cognitive impairment in people with HIV. So this was another study in which they had 3 arms, and they had people who were having a cognitive problems, and the DTG plus Mavroc, DTG plus Mavroc placebo or dual placebo, and neuropsychological testing was repeated at baseline 24 weeks, 48 weeks, 72 weeks, and 36 weeks. And what they found out that over a period of time, they were looking at the total Z score improvement, but there was no improvement in the Z score, and there was no change in the study arms at week 48 or at other points. So there was no evidence to support the use of empiric ART intensification to improve cognitive impairment. So that was there, that even by intensification, you are not able to achieve better neurocognitive functioning. So the last thing is, another thing is TB. We had a lot of discussion, and we keep on having discussion about tuberculosis. There is a growing concern about MDR TB. So in this open label phase 2, phase 3 randomized trial done by the MSF, they wanted to see is that whether the use of the newer anti-tubercular drugs like bedaquiline, pretomalide, linezolid, or bedaquiline, pretomalide, linezolid, and clofazimine, and the other was moxifloxacin, and the WHO standard of care for 36 to 96 week follow-up. And they wanted to see was what was the baseline characteristic. They were all matched as far as the infection with HIV, cavitation, resistance to fluoroquinolones, and they were followed up, and for and the primary efficacy outcomes were modified intention to treat population. So they looked at, and the composite unfavorable outcomes they were looking at, and what they actually found out was that these drugs, if people who were living with HIV with cognitive impairments, ART intensification did not help, and an oral combination of drugs like bedaquiline, pretomalide, linezolid, and moxifloxacin given for 24 weeks was found to be superior to standard of care for the treatment of rifampicin-resistant tuberculosis. And the other combinations were like bedaquiline, pretomalide, and linezolid, and bedaquiline, pretomalide, linezolid, and clofazimine over 24 weeks were also safe and effective against rifampicin-resistant tuberculosis. The only issue is that these drugs are not easily available as of now in the private sector. It's only with the government sector. So maybe probably we will have. So this is what I wanted to highlight in the short span of time. There are a whole lot of newer things which were covered, like the pre-exposure prophylaxis, the long-acting drugs, the capsid inhibitors, which were there, which I could not cover because of the want of time. But for all those who are interested, you can go on to the IS USA site, and it is easily available. So with this, I'll finish off. Thank you.
Thank you very much, Dr. Gogia. I think that is a very crisp presentation of what is practically relevant for us with regard to changing treatment, or, with regard to TB. Any questions? Yes.
Can we switch them to the, instead of the dolutegravir and the lamivudine therapy, to the raltegravir and the lamivudine therapy because of the new onset diabetes after transplantation? Because metformin and the dolutegravir has a lot of interactions. And
Yeah.
those issues are there.
So that is a very practical and relevant question, but we have to look for more evidence before we can extrapolate to the two drugs. So we have the studies which is available with dolutegravir. So with raltegravir, we do not have any hard evidence as of now, but from practical purposes, we think that they probably would be functioning in a similar fashion, but probably we need more stronger data before we can use.
So they are virologically suppressed most of the time.
Yeah,
And,
so that is what, if you talk about evidence-based medicine, yes, there is no evidence, but obviously we consider that they both are the same group, and so probably that can be used in that setting where it is.
Sir, what's your experience with this?
Yeah, raltegravir has a very low threshold for resistance compared to dolutegravir, and so is the lamivudine. So I don't think it will be a good idea till we have strong evidence that
So we need-
raltegravir works. We should not try that empirically.
As of
And-
now, with two drugs, there is although there is enough data now to switches, and a lot of guidelines are recommended to switch to two drug but still in our setting, we have to be very sure, because the follow-up, the compliance, that is very important. The patient has to follow up. If on 2 drugs, they develop resistance or failure, or they are non-compliant, then it becomes an issue. So we have to use drugs which are proven as of now.
Dolutegravir definitely has a higher genetic barrier, and that is required if you're giving it with lamivudine, which doesn't. And the problem with metformin dolutegravir is not so difficult. We just reduce the
It's
dose
just
of
the
metformin.
dose. It's just the dosage which you need to. You can't give him more than 1 gram of metformin. So
Without
probably you can use
evidence-
other anti-diabetic agents and space.
Thank you.
Yeah, you can space. You can give metformin, but the only thing is 1 gram is the maximum dose you can give. So.
So the take-home point is go by evidence. Until we get more evidence, I think intuition has to be kept in check. Thank you very much, Dr. Goge.
Thank you, sir.
Thank you, sir.
Thank you.
So the next session is also a very interesting topic. It is pyrexia of unknown origin, interesting cases from Northern India. To chair the session, I'd like to invite Dr. Chavi Gupta. She's a consultant infectious disease at Fortis Hospital, Noida. Dr. Atul Gogia, sir. Dr. Atul Gogia, sir. Yeah. Senior consultant internal medicine at Sir Gangaram Hospital. Dr. V.R. Subramaniam, sir. And the speaker, Dr. Lieutenant Colonel Sumit Arora. Yeah.
Thank you, ma'am. I'll be quickly presenting 2 cases of PUO, and because of shortage of time, we'll be quick. So I'll start with my first patient. There's a 31-year-old male, resident of Dehradun. He presented to us with chief complaints of fever of 3 months duration, high-grade remittent fever with chills and rigors, and dry cough of approximately 1 month duration, associated with loss of appetite and significant loss of weight. During initial evaluation at a peripheral hospital, he was found to be HIV positive, and past history was significant for allergic bronchitis since childhood, for which he was on and off MDIs. On presentation, he was to our hospital. He was afebrile, pulse was 80 per minute, blood pressure was normal. He had pallor and papular lesions all over his face and trunk and upper limbs, and there was no icterus, clubbing, cyanosis, edema, or lymphadenopathy. These are the typical papular lesions over his upper limb, left upper limb, non-pruritic lesions. I think in PLHA, we are quite commonly seeing these lesions, and they're almost a giveaway nowadays. On systemic examination, his auscultation of the chest showed decreased air entry in the right infra-axillary and infrascapular areas. There were no crackles or bronchial breath sounds. The rest of the systemic examination was normal. Coming to his lab investigations, he had an hemoglobin of 9.9, TLC was quite low, platelet 1 lakh. So he had pancytopenia, ESR was 88, his KFT was normal, bilirubin 2.2, and AST-LT was not significantly elevated, but alkaline phosphatase was 631. Albumin was 2.9. CD4 was 2 cells per microliter. An ultrasound abdomen showed splenomegaly, and X-ray chest showed bilateral diffuse infiltrates. With this picture, this is a young man who's found to be HIV positive and has presented with fever of 3 months duration with splenomegaly, papular skin lesions, pancytopenia. Any differential diagnosis?
So, what was the profession of the person? No,
He was a
profession.
farmer by
Okay,
profession.
by farmer, and he's a resident of Uttarakhand.
Yeah.
So currently in this scenario, I would like to go for some granulomatous disease. Since the ALP is high, there is a pancytopenia. So my DDs would be obviously TB is number one in our country. Next, I would like to go with histoplasmosis also because he's a
Okay.
resident of Uttarakhand. And then we can work up for other things like fungal infections. And since there is a pancytopenia, splenomegaly, I would like to keep visceral leishmaniasis also in one of the DD. So it
Okay.
will involve all the investigations in this in
Any-
current scenario.
Anything else anyone would like to add?
Penicillin malnutrition.
Penicilliosis.
Since
Okay.
it is,
Talromices.
Penicillium we more often seen in Northeast population because
Yeah,
of
absolutely.
the geographical and epidemiological. So histoplasmosis will be
So
first
this
diagnosis rather than
patient,
Talromices.
to the best of our knowledge, has never visited the northeastern part of our country. Yes, ma'am. Penicilliosis is definitely a differential diagnosis along with histoplasmosis, but pardon? Cryptococcus. Yes. So cryptococcus is also one differential diagnosis with disseminated cryptococcosis.
So I think fungal infections in any form with skin lesions, fever in an immunocompromised host with pancytopenia. The other thing is tuberculosis. You cannot never forget it because tuberculosis is something which we see day in day out, and it presents in varied ways. So you can never, leave that out of your differential. You
Sir.
may have pointers, and there may be atypical infections like Bulgardia or something like a brucellosis, because you say he's a farmer by profession. He may be in contact with animal products. So those things also should be kept in mind because there can be granulomatous
Yes, sir.
presentation.
Melioidosis. Absolutely. And what about MAC?
Well, yes, whether
But do you expect MAC to present with pulmonary infiltrates with a CD4 of 2?
Would that?
Yeah, more of a systemic symptoms and abdominal symptoms, lymphadenopathy, with generally the chest being clear. Yeah, okay. So tuberculosis,
these patients can have multiple
Absolutely,
OIs
sir. He
because
may be having-
they are so immunocompromised that they can have a viral as well as a bacterial fungal co-infection. So that also has to be kept in mind. So
Absolutely, sir.
even if you pick up one, you should
multiple
not
OIs
close your
are
eyes to the other.
definitely expected in this situation. So we considered tuberculosis, disseminated fungal infections, and MAC. I still personally feel with such a low CD4, usually you don't find chest infiltrates, but we kept that as a DD. And CMV. CMV, I think with fever, with pancytopenia, with splenomegaly, with CD4 of 2, should always be a differential diagnosis as a coexisting OI. Usually it doesn't go alone. It takes something. CMV is always carries some other OI along with it. So patient was initially started on broad spectrum antibiotics in view of severe neutropenia and cotrimoxazole, fluconazole prophylaxis and supportive therapy. He had 2 episodes of seizures, generalized seizures in the hospital on day 2 and became drowsy, but there were no focal signs. He was managed for seizures empirically with antiepileptics, and an urgent NCCT head was done, which was normal. We went ahead with a lumbar puncture and a bone marrow aspirate and biopsy. And we decided to start ATT empirically and not wait for the diagnosis, confirmed diagnosis. We decided that we can always stop ATT if it is not tuberculosis. Till we get a confirmed diagnosis, we didn't want to waste time, and we started ATT. An MRI brain was also done. So the CSF showed only 2 cells, but that's not surprising in an HIV patient with the CD4 of 2. We don't expect a florid cellular response. Glucose was borderline, not very low. CSF proteins, not very high. ADA was negative. And there were no organisms on Grand stem. Stain or India ink also was negative. AFB stain was negative. Cultures were sterile. The BioFire ME panel was negative, including CMV PCR. Gene expert in CSF was negative, not detected. This was his MRI, which did not show much except for some generalized cerebral and cerebellar atrophy, no meningeal enhancement, and there was some suspicion of sinusitis, which did not correlate clinically. So bone marrow aspirate showed us, the gram stain showed us septate hyphae in the bone marrow. So there is obviously a fungal infection. What would you think of, sir, ma'am?
Now the septate hyphae is there, so our DDs can go towards the molds like aspergillosis, and we should also consider other molds like fusarium, because septate hyphae is a broad thing. It is not a culture sensitive, and considering the skin lesion, sinusitis, aspergillus is more. Then histoplasma and penicillosis is now down the list, because these usually do not present as a septate hyphae in bone marrow. So we can now go for
usually they present as
a yeast
yeast.
form mainly.
So this was
septate
atypical
hyphae
in our
we could
case.
consider aspergillus, and fusarium will also we like to.
But do
because
we
he is a
have the
farmer,
clinical setting for aspergillus or fusarium? Do we have the clinical setting for aspergillus or fusarium?
No, we do not have a clinical
Fusarium, especially, I don't know.
Why I'm saying fusarium, because since he's a farmer, so we can consider fusarium, but it is not correlating. So as you said, and we all agree that we should consider multiple COIs in this scenario, and we should wait for further reports.
Yes, ma'am. So the bone marrow was sent for fungal culture, which came out to be positive after 2 days. These are the septate hyphae. And this is what we saw in the bone marrow biopsy. So there was a cellular marrow with some yeast seen this time. Can you see that on the left slide?
See some septation within the yeast.
Yeah,
in this.
some
So,
transverse
but,
septations in the midline.
I do not agree with the earlier slide. We show the septate hyphae. This is
Yeah,
not looking like
yeah.
a septate hyphae. These are something else. It may be artifact also.
So the bone marrow aspirate may have been a contaminant. Yeah. Okay. So these are typical yeast cells with transverse septation, very typical of penicillosis or talaromyces, as it is now called. So based on this bone marrow biopsy, we made a provisional diagnosis of Penicillium marnifi, or now as it is called Talaromyces marnifi. And on culture, we confirmed this by Talaromyces being a dimorphic fungus which presents in the mold form at 25 degrees, and in the body at body temperatures it presents as yeast form. So we grew this in both forms on different temperatures, thereby confirming the diagnosis of Talaromyces marnifi. This is a lactol phenol blue mount that we did subsequently, and based on these findings we confirmed the diagnosis of Talaromyces marnifi, which did fit in with our clinical picture. How do you treat this patient?
Amphotericin B is the drug of choice.
So we started conventional amphotericin. Patient could not afford liposomal amphotericin, but unfortunately this patient was not keen on further therapy. The prognosis and risk of not continuing therapy was explained to the patient, but he asked for discharge on request, and we could not follow up this patient. But if we would have followed up this patient, we would have put him on amphotericin for at least 2 weeks, followed by itraconazole. I'll come to the detailed treatment. An ART should be started as soon as possible in these patients within 1 or 2 weeks. We don't have to wait. Like in other OIs, we wait for at least 2 weeks, like in tuberculosis. In histoplasmosis and penicillosis, we don't necessarily have to wait for 2 weeks. We can start ART as early as first week if the patient is stable. A few words on Penicillium marnifi, or Talaromyces marnifi as it is called taxonomically named after 2015. First discovered in 1959 by the physician who discovered this was also the first human case, as he accidentally pricked his finger with a needle containing yeast cells of this organism. And there were only a few case reports of talromyces, disseminated talromyces, till in the 80s. HIV patients started developing this infection, and we now have thousands of cases of this infection. This infection is mostly limited geographically to parts of Southeast Asia, especially Thailand, Vietnam, Laos, and in India, the northeastern part of India, as we have said. Infection is rarely found in patients who have never been to these parts of the world. In India, we diagnosed the first case in Manipur in 1998 in a PLHA. And after that, we've had a few hundred cases reported from India. Human and bamboo rats are the only known animal host. And route of transmission is airborne transmission through exposure to soil containing fungal conidia. So it is not a direct transmission from the bamboo rats, but through contaminated soil containing conidia. Mostly seen in immunocompromised patients, rarely seen in immunocompetent individuals, though there are case reports. It's a thermally dimorphic fungus, as we have discussed. Yeast form divide by fission and formation of transverse septum, which is the microbiological hallmark of this organism. And an experienced microbiologist can give you a provisional diagnosis of penicilliosis seeing this picture. This transverse septum is the hallmark. Common manifestations are very similar to tuberculosis and histoplasmosis, with fever presenting in all patients. And skin lesions are late presentations, but seen in almost 70 to 80% of patients in the late stages. And reticular endothelial system involvement is very common with anemia, hepatosplenomegaly, lymphadenopathy in almost all patients. Skin lesions are very typical, and usually they present with papules or molluscum-like lesions with the differential diagnosis of cryptococcosis and histoplasmosis. You can actually do a skin biopsy and diagnose this disease. The respiratory system involvement is common, chest infiltrates. CNS involvement is very rare. And a patient, though he had a seizure, but the CSF did not show any features of infection. Probably just 1% of patients present with meningoencephalitis. So a diagnosis should be considered in an immunocompromised patient, especially patients coming from these regions of Southeast Asia and India, Northeast India. Not necessarily in the recent past, even a remote visit to these regions can be important, because this may be a reactivation in infection after many years also. Patients present with fever, weight loss, non-productive cough, skin lesions, hepatosplenomegaly. Diagnosis is usually microbiological, based on biopsies of the skin, lymph node, or bone marrow aspirate, and staining for fungal stains. And culture is the gold standard, as we have shown. It can be grown at 2 different temperatures. Highest yield is from the bone marrow and the skin biopsy. Serology is not very useful in this diagnosis of this organism, but galactomannan has a strong cross reactivity and strong sensitivity and specificity, but it cannot differentiate between histoplasmosis and penicilliosis. So not really an absolute indicator of diagnosis. So in the end, differential diagnosis can be tuberculosis, melioidosis, and any other disseminated endemic mycosis like histoplasmosis in the setting of an immunocompromised patient. Treatment, irrespective of severity of illness, should be with an induction phase with amphotericin, ideally liposomal amphotericin for 2 weeks. But if amphotericin cannot be given to the patient for some reason, you can use voriconazole, followed by a maintenance phase of oral itraconazole for at least 10 weeks, followed by itraconazole in OD dosing till the patient becomes reasonably immunocompetent. The CD4 should be at least 100 for 3 to 6 months before you stop itraconazole secondary prophylaxis. With CNS disease, we may have to give a longer duration of amphotericin. And heart should be started as early as possible. Now I'll come to my second case.
Dr. Sumit, was there any growth in CSF also in this patient?
No, ma'am. CSF was sterile. There was no stain, microbiology.
Secondly, the pre-test probability of a galactomannan has a cross-reactivity. So septate hyphen galactomannan can be misleading in this case.
Yes, ma'am. Yes, ma'am. So galactomannan is not an absolute reliable test here. Seizures in an HIV patient with a CD4 of 2, HIV per se is known to cause a higher rate of seizures. So it could be metabolic. It could be in a sick HIV patient, almost up to 15 to 20% of patients have seizure due to any unknown secondary cause. So probably it was just an HIV associated thing or sepsis associated, but definitely not attributable to the fungal infection. Any other questions? Now coming to my second case, this is an immunocompetent individual, 42-year-old male, again a resident of Uttarakhand, Nainital, again a farmer by profession. He presented with fever on and off of 10 months duration, cough and significant weight loss. Fever was remittent with intervening afebrile periods and associated with chills, significant fatigue and myalgias. Constitutional symptoms were quite significant and he had been having low backache along with the fever. He had dry cough, but no dyspnea on exertion or chest pain, and significant weight loss in last 10 months. And for the last 2 months, he was also complaining of joint pains, predominantly large joints, symmetrical arthralgia. There was no history of any chronic illness in the past, no history of any drug intake in the past or significant travel history except for coming to Delhi for treatment from Nainital. Treatment history was evaluated at another hospital 2 months back, where the Montus was strongly positive and quantiferon gold test was also found to be positive. But his CT chest was absolutely normal. CT abdomen showed a mild splenomegaly with a small SOL, probably a hemangioma. He was treated with antibiotics in that hospital stay, and he remained afebrile for most of this hospital stay. And hence he was advised discharge and advised to come back if fever recurs. Fever did recur very soon, but he came to us after 2 months of recurrent fever. On presentation, his temperature was 102, his pulse was 88 per minute. He did not have any significant general examination findings. There was no joint swelling or tenderness, and systemic examination, including the fundus, was normal. Lab investigations were also not very contributory except for an ESR of 65. He had mild anemia, TLC platelets are normal, PBS was normal except for mild lymphocytosis. His liver function tests were normal. Albumin was marginally low with a fever of 10 months. That's not surprising. His KFTs were normal. His blood and urine culture turned out to be sterile. The X-ray chest was normal and ultrasound abdomen was normal. His HIV and other viral markers were negative. So here we have a young individual who has no apparent any immunocompromised state, but he has come with a fever of 10 months duration, almost persistent with very few intervening afebrile periods, with significant myalgia, joint pains, backache, and no other systemic findings or symptoms. So what all do we think of here?
Earlier, you mentioned that in the first admission, he presented with fever and cough. So when he
had
revisited,
cough even now.
The cough was resolved.
Dry cough
Now,
is there.
Okay. So he had only fever. So it's a fever with weight loss, we can say. And we have only evidence that ESR is high and quantiferon is positive. And so we would like to go by our conventional DDs like tuberculosis,
Yes,
which
ma'am.
comes, and I would also like to work up for the infective endocarditis in this case because he
Okay.
had arthralgia and there is a remittent fever and fever periodicity, visceral leishmaniasis we should also look for, and then we can.
He doesn't have any pancytopenia, and the spleen is
Yeah,
also
but,
not very big.
In
No
PO
skin
workup,
lesions.
in Indian, we
Yes,
should
definitely.
do the
It should be a
RT39
DD.
in this case. And then another investigations like echo, CT, abdomen for workup of PO first, and then we can streamline that.
Okay. So his VDRL is negative, his thyroid profile, cortisol is negative, vasculitis profile is also negative, his echo is normal. Repeat CT chest and abdomen, the chest CT is still normal. And in the abdomen, he has some small peripancreatic and periportal lymph nodes with mild hepatosplenomegaly. Now, this patient does not have anything in the chest, and his echo is normal. Metabolic profile also is normal. Common causes of endocrine causes of fever also ruled out. So what are we left with?
So it is really challenging. These are the kind of cases which are really challenging, where you are not able to pinpoint where the source is and what is the focus is. So probably he has a relapsing remitting kind of a course. So some chronic granulomatous infection is one probability. Tuberculosis always stays number one. Number two are fungal infection. Sometimes histoplasmosis may present, as a slow smoldering fungal infection, which may present, this kind of a picture. The other things could be non-infective causes, obviously, although we are in SIDS and we are talking about infections, but we need to keep our eyes and brain open to non-infective causes like
Absolutely,
sarcoidosis,
sir.
lymphoma, which also should be there in our mind while we are looking at these patients. And
Sarcoidosis, would you expect with a normal chest CT? It is
yeah,
possible,
it is
but
very, very
rare.
unusual. Yes, very, very unusual. But now we are talking about an unusual patient where you worked up
In
and
an ID
everything is
forum.
an ID forum, and it has been worked up to quite a bit of an extent, and we've not been able to reach to what the focus is. The other thing, obviously, we can think of an occult malignancy. That is one thing which is there. Other thing is we need to, the important thing, especially for the juniors and trainees who are here, is to go back to the history once again, and probably that might give us a clue in this patient. What is the patient profile? What is the day-to-day functioning of this patient? What is his contact? You say he's a farmer.
Yes, sir.
So farmer, but similarly, whether he has any contact with animals, animal products. So whether it is some kind of an infection, zoonosis are things
Absolutely.
which may be there because
So,
of the profile of the patient. So,
everyone in his village has cattle, including him.
So, or he had any history of ingestion of any unpasteurized milk, or he had arthralgias and some backache and weight
Absolutely,
loss.
sir. Absolutely.
So that can be something which can be thought of
Absolutely.
apart from obviously.
Lyme's disease is a possibility, but
And we should also consider the bone marrow in this scenario because we are not having
Yes.
still having any
So-
diagnostic clues.
coming to the bone marrow, the bone marrow aspirate showed a granulomatous lesion, but AFB and CB-NAT were negative. But TB still remains a possibility.
TB and histoplasma can.
Brucellosis, absolutely, they mentioned, sir. Tick-borne relaxing fever, like babesiosis. Yeah, but it's definitely a positive possibility.
Still in our country,
Yeah, it's a possibility theoretically. We should look for it. It's not at all common in India, but yeah.
now we should specifically go for the DDs of the granulomatous
Yeah.
lesion.
So, so we kept all these DD in mind: tuberculosis, fungal infections, Kala Azar, brucellosis, and non-infective etiologies like adult onset Still's disease was still, it's not a typical presentation, but possible 10 months of fever and joint pains with high ESR. And lymphomas were definitely still a possibility, though the bone marrow has shown a granuloma, which is still possibly a Hodgkin's lymphoma. Occult malignancy, solid organ malignancies, 10 months of fever with no finding, other findings is unlikely, but yes. So all these are possibilities, but we did find an infection. The bone marrow culture, surprisingly, and to the credit of our microbiologist, grew Brucella melitensis, and we confirmed brucellosis. And going back, there was an indication in the presentation. Sorry. How can we go back to the presentation? Can we switch on the presentation again? Patient had relative bradycardia. So that also, it's not a very specific finding, but since this patient did have brucellosis, so it becomes an indicator of a chronic granulomatous infection with relative bradycardia. Brucellosis does come to mind. So we treated him with doxycycline for 6 weeks plus streptomycin for 2 weeks, which is the recommended treatment. Doxycycline for 6 to 12 weeks and streptomycin for 2 to 3 weeks. Brucella is a zoonotic infection caused by a gram-negative aerobic cocobacillus. Human-to-human transmission is rare, usually transmitted by close contact with animals through broken skin, mucous membranes, aerosol, or ingestion of unpasteurized milk and cheese, like sir had mentioned initially. Commonly seen in slaughterhouse workers, farmers, shepherds, veterinarians. Can present with acute, subacute, or chronic picture. I'll skip through all this. The treatment recommended is doxycycline plus streptomycin. Second option is doxycycline plus rifampicin. Cotrimoxazole and fluoroquinolones are also recommended. Neurobrucellosis, you give ceftriaxone and the treatment is longer, and 3 drugs. Thank you very much. I'm sorry for overshooting the time.
I'm sure that this was the most challenging and interesting part in our day-to-day practice. PUO remains the most challenging thing. It is like a detective going after and finding the culprit. So it is really challenging, and I'm sure Dr. Sumit discussed the 2 cases well. So we'll close this session and move on to the next session. Thank you all. Thank you, Dr. Sumit. Thank you.
So moving to our next talk, it is CMV infections in HIV. To chair the session, I'd like to invite Dr. Ruby Bansal. She's a senior physician and with a special interest in HIV medicine. Dr. Chavi Gupta, consultant infectious diseases at Fortis Hospital, Noida. And as a speaker, Dr. Neeraj Nawar. Dr. Dheeraj Nawar. Yeah.
Should we start? I'm presently working in Base Hospital. As a disclosure, I am not an infectious disease specialist. I am a general physician. I have done some training in geriatrics. So I do look after geriatric patients. And since I am in an army and you have to have in multi-roles, so off and on, you see a lot of infections. And so as a physician, you can come across a lot of infections. And since we have not a separate HIV specialist posted to us, although Base Hospital is lucky enough to have Col Sumit Arora who is looking after our HIV patients, but most of the places HIV patients are generally looked after by physicians like us. So we have to do multitasking. So I was given this topic by Col Sumit Arora to speak on CMV. I would start with a interesting case which we have just come across.
Can I have a slide change? So we had a 39-year-old male who was initially detected to be HIV positive in November 2011. And when he presented with disseminated tuberculosis, he was started on ATT as well as ART since November 2011. And from 2011 to 2016, he responded poorly with multiple OIs. He had pneumocystis, then he had fungal pneumonia. So he was shifted to second line ART. After he was shifted to second line ART, he had good response, but he on his own stopped his ART in 18-19 and again developed features of diarrhea and weight loss. He was again restarted on ART and shown a good response. But again, then lockdown happened and he was not able to come to us. So he again stopped it and then presented in October 2022. Again, he started on to the second line ART, which was ritonavir lopinavir based. So then he presented to us in around January with history of with altered sensorium, some bowel bladder and with decreased mentation, drowsiness, and bowel and bladder incontinence, and mild left hemiparesis where the power was around 4/5. So we initially, on the basis of poor compliance and progressive disease, we diagnosed as HIV encephalitis. His TLC was 2,800 and sodium was 124, which may have contributed to some amount of his drowsiness, but he didn't improve after correction of sodium also. We did a CSF which showed around 10 RBCs, 20 WBCs, and which was predominantly lymphocyte. Sugars were decreased and globulins were increased, but ADA was only 4. We did a CE-MRI which shows this heterogeneity enhancing and non-enhancing lesion in corpus callosum, periventricular and subcortical white matters, and diffuse brain atrophy. So his CMV RNA was 1.6 into 10⁵, and PET CT FDG, we did a PET CT also, which showed FDG avid lesion in right frontal gyrus, increased periventricular uptake with multiple area of fibroconsolidative lesion in both lungs. So on the basis of on the basis of immunosuppression and PET CT finding, we made a diagnosis of and CSF finding, we made a diagnosis of tuberculosis, although ADA was not contributory, and we started on ARTT. We continued the ART, and post ARTT he had mild improvement. He had intermittent drug-induced liver injury. We gave him modified ATT, when then again shifted to normal ATT. But we were not he was not improving. So we decided, we had a DD of CNS lymphoma, so we decided to have a brain biopsy. So he underwent a cortical biopsy, which showed only benign neuroparenchyma. So it was non-contributory. We did bone marrow biopsy to look for the lymphoma, which was also not contributory. And then we repeated the MRI brain when because he had shown some partial improvement, and which had shown partial resolution of the lesion, pre-existing lesions. Then he developed multiple discrete perianal ulcers, which we thought maybe because of CMV. We did a fundus examination because the dictum is that most of the brain infection, if it's a CMV encephalitis, they should have CMV retinitis, but to our surprise, there was no CMV retinitis. And he didn't have any signs of HIV retinopathy also. Although his CSF show was positive for CMV DNA and HSV6. So what is the diagnosis? We will come to it at the end of presentation. We'll give panel to ponder upon.
I would like to know what was the CD4 count, and considering the CMV in serum was copy number was very high.
Yeah. So,
and the no CMV treatment.
See, we are not doing CD4 count now as a routine. We are doing only HIV RNA because there is some on administrative issues, and only we are not following CD4 count because we have no in-house CD4 count facility. So we generally follow up the patient on HIV RNA.
And why did you go for the CMV RNA in the first go? Because CMV DNA, because we usually do not practice CMV viral load in such.
We did it because that discrete perianal ulcer has some we were suspicious of CMV. We did a biopsy also for that. So we kept a DD of CMV encephalitis as one of the
And what about the JC virus in the CSF? It was negative.
JC virus, we didn't do it. See, we have a limitation because we have limited resources, and most of the time which we have to do all these resources, the patient has to pay. So that comes as a roadblock. So for my younger postgraduate colleagues also, basic PG trainees, so I would like to cover what is CMV. CMV is also known as human herpes virus 5. As an immunocompetent, we don't come across with CMV disease. So it's a large and complete double-stranded DNA virus. Why? Because it generally doesn't affect the immunocompetent person. It occurs, but it is very ubiquitous virus. It generally transmits by intimate contact through oropharyngeal secretion, and most of can get it during birth or during childcare time, because it can transmit through cervical and vaginal excretions, through breast milk, tears, feces. So there's a lot of ways it can be transmitted. And then once it infects us, it becomes a latent, it goes into a latent phase. Most of the studies which have been done had shown that the prevalence, these are all seroprevalence studies where they have measured IgG, and they have shown that almost 60 to 90% of us are infected with CMV. In India, in fact, there are certain studies which have shown almost 100% seropositivity for CMV, especially in 40 to 50 age groups. Apart from the last study which was done in HIV seropositive patients in Delhi in 2014, most of the studies had been consistent, which had shown around 70 to 90% seropositivity for CMV. So almost all of us are infected with CMV. But we generally don't show any infection because of cell-mediated immunity, which take care of this viral activation or viral multiplication, and they don't allow the viral replication to reach to a level which can cause end organ disease. Occasionally, we can present like infectious mononucleosis kind of feature, where we have to differentiate this infectious mononucleosis from EBV associated with infectious mononucleosis. The differentiating features are EBV generally involve pharynges and all, and it spares pharynxes. However, since as an immunocompetent, we are not bothered about CMV, but it can complicate pregnancy and cause. It is the commonest cause of congenital infection, and it is a very important opportunity infection in solid organ transplant, bone marrow transplant, and HIV. And inflammatory bowel disease, around 10 to 36% of active ulcerative colitis patients are infected, may present with CMV, and there it also becomes difficult to differentiate between CMV colitis and exacerbation of ulcerative colitis. So you have to resort to the biopsies. Primary CMV syndrome, I've said it's generally asymptomatic, sometimes can present an infectious mononucleosis, then it cause a latent phase where it is kept in check by our immune system, and then it have intermittent reactivations where it can be detected by BCR or serology. And then it can cause CMV end organ disease. This is mostly commonly seen in whenever you are immunosuppressed. So CMV end organ disease can present as CMV syndrome, which is nothing but basically in a immunosuppressed patient who presents with fever, with new fatigue, and with malaise, and more than 5% atypical lymphocyte with some thrombocytopenia and some hepatitis. CMV syndrome can be considered, but it's very difficult to diagnose when there are multiple OIs present. Invasive diseases are retinitis, then can cause GI, where it can cause both colitis, esophagitis, hepatitis, and pancreatitis, then pneumonitis, and again neurological diseases like dementia, ventricular encephalitis, and polyradiculomyelopathies. It can infect kidney, and in fact it can infect any organ of the body. But these are the most common which gets infected. But the diagnosis of end organ disease require classical symptoms plus histopathological diagnosis of the presence of CMV in that organ. Pathophysiology basically, protection from CMV is given by cell-mediated immunity. Humoral immunity has no role. So CD4 and CD8 cell basically gives immunity. CMV specific CD8 cells keep the CMV infection in check. So that's why it is more common in immunosuppressed, more common in HIV, where your cell-mediated immunity goes down. And it activates when CD4 cell count is less than 100. In fact, earlier 45 to 60% patients used to develop circulating CMV during a period of over 6 to 12 months. It is a study done by where they have shown that patients who have less than CD4, less than 100 CD4 count, 52 of around 50% patients had shown CMV viremia. So how do you diagnose? Diagnosis by serology. It is not very good test. It is generally used for screening, where you can do IgG and to see whether the patient is CMV infected. And it is not good test for immunocompressed because they may lead to false negative results. Then second is viral culture. Viral culture is difficult, takes long time, and it has a very poor detection rate. PCR is gold standard. It has a short time, high sensitivity, and it can catch hold of around 60% of viral infections. And it can be done in variety of samples, from serum to tissues and CSF. Another is CMV antigen assay, which is not done routinely in immunosuppressed because it has limited clinical utility in leukopenic patients. But in studies done, it has found to be same sensitivity as viral culture. Then last is histopathology, which shows typical nuclear inclusion body giving an owl eye appearance, which is owl eye inclusion. And this is must for diagnosis of end organ disease. So in pre-heart era, the CMV was very common. We had around most commonly they used to involve retina. Around 40% of AIDS patients in their lifetime would have retinitis, and they represented 85% of all CMV end organ disease. And this was followed by gastrointestinal disease, and then other diseases like neurological and pneumonitis. Pneumonitis is very rare in HIV. So there are various studies which had shown that CMV disease was around 40%, 40 to 50% of patients were infected by CMV, and around 40% had CMV ophthalmic retinitis. But post-heart, introduction of heart has changed the scenario. The heart has decreased the incidence of viremia and has improved the immune response. So this has led to the change in scenario. So post introduction of a heart, these are the features: good CD4 T cell counts, less of HIV viral load, and increased CD4 circulating, CMV specific circulating CD4 and CD8 count has ensured that CMV viremia is controlled over a period of time if the patient is compliant with heart and had good immunological response. But post heart, the risk factor remains same. CD4 count is less than 50-100 with CMV reactivation, and HIV viral load more than 1 lakh is still the risk factor for CMV disease. And in fact, the CMV viremia is and CD4 T cell counts are correlators of mortality rather than HIV viral loads. Again, heart decreases HIV replication and increases CD4 cell count. That is a protective measure for CMV, as we covered in pathophysiology. And this has caused a decline in CMV retinitis by 80%. So, in fact, in a study by Perello, who had done a study in HIV patients, the incident of acute CMV, they compared the pre-ART era and their studies. They have found that the incident decreased by to 1.7 cases by per 1,000 patient years, as compared to 7.35 per 1,000 patient years, which was in pre-ART era. And they also showed a 30-day mortality of 18%. And to the surprise that they have not reported any ophthalmic manifestation of CMV disease, which was found to be very common in pre-ART area. They had most common was CMV syndrome, followed by respiratory manifestation. Another study had shown that they had done in Spain, where they have shown that there was 7 to 72% reduction in CMV infections and around 52% reduction in CMV retinitis. They have also described a CMV immune recovery vitritis, which is basically an inflammation of posterior chamber, and the patient may have worsening visual disorder. They can have macular and disc edema, neovascularization, and loss of visual acuity. Although in our experience, we have not come across CMV vitritis till now. As per their study, they said posterior 15 to 90% of patients of previous CMV retinitis can present with vitritis. Our experience in base hospital, we have retrospectively studied around 940 patients from 2018 to 2022, and we did not screen them for CMV infection routinely, but we depending upon the end organ disease manifestation, we diagnosed 14 patients as CMV end organ disease, out of which CMV retinitis was commonest. 8 patients were out of 14 were CMV retinitis. But overall, if you see, it causes only 0.84% of the total patient which we have screened, which has called end organ disease. In fact, this is consistent with the recent studies which have shown only 1 to 7% of CMV of HIV patients presenting with retinitis. And most of the patients we treated with oral valganciclovir, and they have responded well. A word about CMV in immunocompetent. CMV in immunocompetent can present in critically ill patients where serious organ involvement is around 10%, but the spectrum is, again, they don't generally involve ophthalmic disease. They involve hepatitis, gastroenteritis, colitis, and proctitis, and sometimes then followed by CNS infection. So after introduction of heart from pre-ART era, where we were immunosuppressed, where the commonest manifestation was retinitis, and in immunocompetent, where the commonest manifestation is GI, we are somewhere in between, where now the CMV retinitis has come down, and we are seeing more of CNV encephalitis, CNV GI manifestation, as well as some amount of CMV pneumonitis also. What about treatment? Well, ganciclovir IV is recommended as for antiviral prophylaxis. Oral ganciclovir, valacyclovir also can be used. But for treatment, only 2 drugs, valganciclovir and ganciclovir, is recommended for treatment. Foscarnet can be added to valganciclovir, and cidofovir generally we don't use. We are in our center, we are using valganciclovir and ganciclovir plus foscarnet. For prescribed prophylaxis, primary prophylaxis is not recommended with valganciclovir. Although secondary prophylaxis has to be started in a patient who has recovered from CMV disease, and it has to be continued till you get a good suppression of, you get a sustained increase in CD4 cell count for 6 months. Although in those patients who had a good immune response to ART, they can still have CMV diseases. The recent thing is immunization is more for solid organ transplant and bone marrow transplant, which there is a lot of vaccines which are under development, which are going into phase 2, phase 3 trials, and maybe in another 2-3 years we will get some vaccine for CMV also. In conclusion, CMV remains an important OI in HIV, and with the introduction of ART, the spectrum of CMV disease has changed. Earlier, retinitis used to be there in 40 to 50%. They used to develop. Now, retinitis is around 3%, 7 to 7% in the various studies which have shown, and we are seeing other common causes. And CMV disease, we have to be very aware that earlier, if you are suspecting CMV disease, you used to do ophthalmic examination and take retinitis as a correlation of CMV disease. But now we are seeing patients with CMV disease without any retinal involvement. So I conclude. So the question remains, what was the diagnosis?
So the current scenario, we can go with the CMV encephalitis.
And there was two things in there. We had considered CMV retinitis, and second he had HHV6, which was also positive. But we went with CMV because of the first radiological picture. HHV6 mostly involved temporal and mesial lobe. It has involved basal, its periventricular areas, and some subcortical white matter. So we started the patient on oral valganciclovir. He had other problems also, and he has marginally improved. He has not become totally funny. He has become alert, but he has not fully recovered. So we are still following up the patient, and we are going with the diagnosis of CMV encephalitis. The only thing that we brought up the patient is he had CMV encephalitis, but he had no CMV retinitis. So that is the picture which is now emerging over a period of time.
So you have treated him with ganciclovir?
Oral valganciclovir.
So he showing the response?
He has shown partial response. His mentation has improved. His paralysis was not there, but he has now developed basically both osteoarthritis, both knees. So that way he is still bedbound.
What about the ART?
He is continued on ART.
On the lopinavir based regimen or what?
No, ma'am, he is on TLD now.
He's on TLD. So he has just switched.
That
with
is
the
because
three.
we have shifted. That is because of some administrative convenience also, decreased pill load also, that kind of.
No, you have shown he has just adherence was very poor. So multiple times
Initially his adherence was good. Then once he's left it, then since he is not of Delhi, he is from Jhansi, and there is a difficulty in availability of all these ART medicine because this only present in ART centers, and small hospitals generally doesn't cater for those. So when the lockdown happened, he was not able to get it. That was a problem. So most of our small hospitals doesn't cater for these ART medication. That was a problem. So when the lockdown stopped, he came in October and we restarted him.
So you have seen the increased viral load or what? How you have like
Follow up during
follow-up.
CMV viral load, and what about the perineal lesions? Did he? Yeah.
Perianal lesions were suggestive of CMV ulcers.
Did they responded with the treatment like?
Yeah, they have gone.
And any follow up with the CMV?
He is
viral
still in
load
the hospital. Maybe we have not repeated CMV viral load again till now.
So I think maybe we can expect, although time is short, we may not consider the more comment. But the one take-home message is, I mean, is still in all HIV patients, we have to look for. I mean, we should not miss any opportunistic infection, which can be there sooner or later. We have to find out, and it is all about the digging the patient. So how you can just say, well, history taking, it's all about all the tests, the pre-ART. I mean, before started the ART, we need to look for the all OIs, and the fundus examination is an important thing, which we are not using usually, but we have to do it.
Actually, people are earlier recommended to do fundus examination of CMV retinitis every 4 to 6 months. But with the change in spectrum, I don't know how much it is going to be beneficial.
No, but the recent guidelines is like with the heart, the CMV retinitis incidence is very low. But
Yeah,
now we are.
That's most. It is around 3%.
I also like to add in this that we do not have any established cutoff to treat CMV viremia. Although we are doing it in our transplant settings, but in HIV settings, we do not have any established cutoff. So as much as bigger we go, we may get confused during the treatment because sometimes CMV do not require treatment in cases of viremia.
Yeah, most of the guidelines say the CMV has to be treated when it manifests as a disease. Now, another option is CMV syndrome is very difficult to diagnose. In that study, they have diagnosed and they have.
Confusing and challenging in these scenarios.
So thank you very much.
commonly in all pregnancies, gynecologists write for the screening of torch infection. The speaker for this talk is Dr. Tanu Singhal. She's a pediatrician and consultant infectious diseases at Kuldeep Astha Hospital in Mumbai. She has many publications, research publications in the field of infectious diseases. To chair the session.
Hello.
So again, once again, torch infection is the topic, second last topic for today's session. Dr. Tanu Singhal is the speaker. She is a pediatrician and consultant infectious diseases at Kuldeep Hospital in Mumbai. She has many research publications in the field of infectious diseases. To chair the session, I like to request Dr. Chandra Mansukhani. She's a senior gynecologist at Sir Gangaram Hospital, and Dr. Shweta Goswami.
Good afternoon, everyone. As our speaker is Dr. Tanu Singhal. She's a senior pediatric infectious disease specialist at Kuldeep Hospital, Mumbai. She's going to speak on torch infections. So let us first listen her.
Good afternoon. I'm Dr. Tanu Singhal, and I'm going to be talking to you about torch infections. With that, let me share my screen. So, torch infections basically refers to infections in pregnant women and neonates. And the acronym TORCH or TRCH actually stands for Toxoplasmosis, Rubella, CMV, and HSV. Whereas the O is actually an ever-expanding group, and it includes many infections like chickenpox, syphilis, malaria, chikungunya, tuberculosis, HIV, HCV, hepatitis B, HHV, enterovirus, parvovirus, and Zika. And in this, malaria and tuberculosis are especially important in the Indian setting. So when we talk about the TORCH screen, it actually refers only to serology for TRCH, which is only a subset of infections in pregnancy. But today, I'm going to be talking about only the TRCH group because the serologic diagnosis of these 4 infections is one of the most challenging and confusing. So one must remember certain basic principles of the torch infections. First, that these are generally silent and have mild consequences in the mother, but they can have disastrous fetal or neonatal outcomes. Another important concept is that damage to the fetus happens usually following primary infection because it is at this time when the viremia is unchecked because there are no existent antibodies. Also, the consequences are greatest when infection occurs in the first trimester of pregnancy because this is the period of organogenesis. The lab diagnosis of these infections is complicated and confusing, as you will see in the cases that we discuss, and it often leads to difficult management decisions, which include fetal diagnosis like performing an amniocentesis and even doing a medical termination of pregnancy. But the biggest paradox is that when torch infection is suspected in pregnancy, the baby is usually normal. And most of the cases of torch infections are actually diagnosed in retrospect once a baby is born and we as pediatricians see certain abnormalities. So what are the situations when torch infections are suspected by gynecologists? The first is an abnormal torch screen, and this is the most common scenario. Usually it is a false alarm, and the torch screen should not be done unless it is clearly indicated. Other situation is when there are recurrent abortions. But remember, it is only syphilis which causes recurrent abortions and not the others. So if somebody has recurrent abortions, the important test to do is a BTRN or an RPR. Unexplained fetal IUGR is also a situation where torch screening is requested but the yield is very low. Similarly, when there are certain ultrasound abnormalities like hydrops, echogenic bubble, microcephaly, brain lesions, a TOT screening is requested, but most of the times the investigations are non-conclusive. Sometimes when the mother has fever with or without rash, a TOT screen is requested. But remember that many a time these infections are go silent and unnoticed in the mother. And then finally, as I said earlier, this can also happen when you see an abnormal neonate and infant. But in this presentation of mine, I will discuss the diagnosis of TORCH infections in the pregnant woman and not in the neonate. Now, there are certain principles about serologic diagnosis which we must remember. That first, serologic diagnosis is based on both detection of IgM and IgG, and the current methods which are used for serologic diagnosis include ELISA and CMIA. And we don't use methods like latex agglutination, complement fixation, etc. And therefore, one cannot accurately estimate the rise in titers, because for this, you actually need the resultant dilution, whereas the rise in optical density in these tests does not mean a similar rise in titers. Now, IgG is important because if it is negative, it rules out the infection convincingly. However, a negative IgM does not rule out acute infection, because in some cases, especially in CMV, you may have an acute infection and yet the IgM may not rise. Besides, an IgM is not specific for an acute infection because it often lasts for a long time, between 3 months to 1 year. And therefore, if a patient is both IgG and IgM positive, one has to do an avidity index to understand whether this infection is old or new. The avidity index is based on the concept that when a patient has an infection, the initial antibodies which are produced bind imperfectly to the antigen, and therefore they have low avidity. Whereas as the infection matures, the antibodies also mature and the avidity index increases. There are lab and kit variations, and therefore if one is sending a screen, they should send it to a reliable lab. But often it happens that you send the test to 2 reliable labs and the results are discrepant. And finally, the positive predictive value of the test depends on the pre-test prevalence. So if a TORCH test is sent when the likelihood of this infection is low, most of the positives will be false positives. Now, besides serology, ultrasound and amniotic fluid molecular methods are also used for diagnosis. So with that basic knowledge, let us come and discuss the first case. Now, this first case is a 32-year-old woman which I saw a couple of years ago. She had taken pre-pregnancy counseling, not with me, and a TORCH screen was requested, and the toxoplasma IgM and IgG came positive. Now, this patient was advised to delay pregnancy till the IgM becomes negative. She repeated her IgM after 6 months. It was still negative. So, do you agree with this approach? Is this what should I have done? So, to understand this, you must understand some of the concepts of toxoplasmosis. Now, toxoplasma is a common infection in pregnancy in countries like France, where they eat undercooked meat. And therefore, in France, there is universal screening for toxo. The infections in the mother are generally subclinical. Rarely she may have fever or lymphadenopathy. And as I said earlier, the risk to the baby is only with primary infection in the mother. And if a mother indeed has primary toxoplasmosis, then she can have serious outcomes like abortion, stillbirth, or neonatal disease. Now, as you can see from this table, the risk of fetal infection rises as trimester advances because the placenta becomes thin. But the risk of fetal infection is actually highest in the first trimester, which is the period when organogenesis is happening. Now, congenital toxoplasmosis can be quite a devastating illness characterized by hydrocephalus, intracranial calcification, and ocular involvement with chorioretinitis. But it is a diagnosis which should not be missed because it can be treated with pyrimethamine sulfadoxine. Now, let us talk about the interpretation of toxoserology. So, if a mother is IgG positive and IgM negative, then it means that she has had past infection and there is no need to worry. There is no risk to the baby. If she's IgG negative and IgM negative, it means she's susceptible to toxo, she should be advised about precautions such as avoiding eating uncooked fruits and vegetables, avoiding eating undercooked meat, avoiding gardening, etc., and exposure to cats. But you don't need to repeat the toxoserology in pregnancy. The problem happens when she is both IgG and IgM positive. Now, in this case, you have to do, it could mean that there is infection in the past 1 year, and you have to do an IgG avidity test. If the IgG avidity is high, it means she got the infection 5 months earlier, and therefore it means it's an old infection, and probably it is not a risk to the baby. Now, however, suppose somebody has done this toxoserology in the last trimester and the avidity comes high, it may still mean that she got infected in the first trimester, and therefore this rule does not apply then. Whereas if you've done the IgG and IgM and they are positive in the first trimester, it really means that she was infected before pregnancy and the fetus is not at risk. The IgG negative and IgM positive is the most dangerous setting because here it means that the baby has had acute infection. You reconfirm the diagnosis. Also, if she's IgG and IgM positive and the IgG avidity is low, it again means that it's a recent infection. Now, in this situation, actually you do an ultrasound and you may also decide to do a PCR in the amniotic fluid. And if the PCR is negative, it means you can give the mother spiramycin to prevent fetal infection. Whereas if the PCR is positive, you either do an MTP or you give pyrimethamine sulfadoxine for the rest of pregnancy. And you may also consider an MTP. So you can see that actually the indications for spiramycin in pregnancy are very few. Whereas what you see in the clinical practice is that many women who have had either a positive toxoserology, either IgG or IgM, are often given spiramycin unnecessarily. So coming to this patient, she's IgM and IgG positive. It means infection has already occurred. She's immune. She can conceive right away, and we should not repeat the toxo-IgM. We should not give her spiramycin. And also this brings this important message home that routine torch screening should not be done. And if you have to do routine screening, you should do it for HIV, hepatitis B, and VDRL. Coming to the second case, this is the case of a 28-year-old primate gravida who on a 16-week ultrasound shows an echogenic bubble with no other abnormalities. And because of this, the lady is advised TOT testing. She does do it, and you find that she's both CMV, IgG, and IgM positive. So from this result, can one conclude that she has actually a CMV infection of the fetus, which is giving rise to the echogenic bubble. But it is not that easy. And so if you have, remember that if a mother has CMV infection, it can be either a primary infection or it can be non-primary. Now, in the Indian scenario, 99% of the mothers are CMV positive before they become pregnant. So therefore, they cannot have primary infection. They can have only non-primary infection, which is reactivation of the CMV or reinfection. This is really important because it's only in primary maternal CMV there is a very high risk of fetal infection to the tune of 30 to 54%. Whereas if she has CMV reactivation or reinfection, the fetal infection rates are very low, only 1 to 3%. But if the baby gets infected, then whether it was due to primary maternal CMV or non-primary maternal CMV, the outcomes are the same. So in 10%, the disease is symptomatic. And of all the babies who are symptomatic, 30 to 90% actually have sequelae. Whereas if there was asymptomatic infection, then still, even they are normal at birth, these babies may go on to have sequelae later. And the most important consequence is sensory neural hearing loss. So it would appear that most of the cases of congenital CMV disease occur following primary maternal CMV, but that is not the case because this is an infrequent occurrence. So half the burden of congenital CMV is due to reinfection or reactivation in previously immune mothers, and most of the cases which happen in India are in those mothers who have reactivations or reinfections. And this is just to tell you about this baby who came to us with apparent hydrocephalus. And when we did a CT scan, we found that he almost had only CSF and very little brain matter, and this was due to congenital CMV. So it can be quite a devastating disease, and it is one of the commonest causes of sensory neural deafness in children, and it is actually the most common congenital infection. So the diagnosis also of CMV infection in pregnancy is complicated because a positive IgG is nearly universal. I still have to see a woman who's CMV IgG negative. And if IgM is positive, like which happened in our patient, it can even be due to a reinfection, reactivation, or it may be a carryover from a root infection. And if this is the situation, the risk of fetal infection is actually very low. Also, the other thing is also true that IgM may be negative even in acute infection, because the tests which are available for detection of CMV IgM are actually imperfect tests. Therefore, if there's a strong suspicion of CMV infection in pregnancy, then the reliable test to do is an amniotic fluid, CMV PCR. But let us say one would detect a CMV infection of the fetus. There is nothing you can do because there's no therapeutic intervention you can offer. The randomized control trial with CMV hyperimmune globulin did not show any benefit. There is a recent study which shows that if a woman has primary maternal CMV, then she can take high-dose acyclovir throughout pregnancy, and that could reduce the risk of infection of the fetus. But primary maternal CMV infection is a rarity in India. So therefore, doing a CMV serology in a pregnant woman is like opening a Pandora's box, because it is so difficult to interpret the results. So when we come back to our case, this lady who had an ecogenic bowel, whom the fetus had an ecogenic bowel and was CMV, IgG and IgM positive, we did a IgG avidity. The IgG avidity was high, showing that probably this was a lady who had either a reinfection or reactivation. She did not consent for an amniocentesis. After 2 weeks, the repeat ultrasound showed resolution of the ecogenic bowel, and there was a healthy term baby who was born with no stigmata of CMV. But this woman actually had a very difficult time during pregnancy, because all the time she was worried about what could happen to the baby and whether the baby would be normal. And we have also seen situations where just because of a positive TORCH serology, there are women who have actually opted to do a medical termination of pregnancy, which is really very unfortunate. Now, this third case is slightly different, because this is a case of a 25-year-old primate gravida who is in her first trimester. She has not received MMR vaccination, and we do not have her antenatal rubella serology available. She is exposed to a child who has fever and rash, and she is concerned because if that was rubella, she would get infected, and that would be dangerous for the baby. So how are you going to approach this problem? So one must understand some of the important things about rubella as an illness. So rubella may not always be symptomatic. There are high rates of subclinical infection. Usually it presents with low-grade fever, sore throat, tender nodes in the retroauricular region. If you examine carefully, you'll find some petechiae in the palate. And there is a rash, which is erythematous maculopapular, which begins on the face and goes down. But rubella really resembles many other exanthematous illnesses like Roseola, Infantum, or measles, or a drug rash. And therefore, if you have to confirm the diagnosis, you have to do a rubella IgM in the index patient. But if a woman gets rubella in pregnancy, it's one of the most teratogenic of all illnesses. There can be several consequences. And in fact, rubella in the first trimester is the most dangerous, where the rate of fetal damage is about 70 to 90%. And the most common abnormalities which you see in the baby are heart anomalies like PTA, cataract, deafness. In fact, some of these babies have developed diabetes, mellitus, and many other complications later. Whereas if infection occurs beyond the 16th week, then there are no consequences. Because rubella is a very dangerous illness in the first trimester, if you have confirmed rubella in the first trimester, it is an indication for medical termination of pregnancy. Probably the only indication for MTP due to a TORCH infection. Now, what is more commonly seen is a woman who takes MMR vaccine and then discovers that she is pregnant. There is no indication for MTP here because Though MMR vaccine is contraindicated in pregnancy, if someone takes it accidentally, studies show that there's no risk to the fetus. So the woman can actually continue with the pregnancy. So how would you manage this case of any exposure to rubella? So first of all, you would do a rubella IgM in the index case to make sure that it is indeed rubella that we are dealing with and not any other exanthematous illness. And if that was positive, then you would do a rubella IgG in the lady. And if it is positive, then it means that there's nothing to worry because she's immune and she's not going to get infected from this exposure. The same principle applies to chickenpox, that if a pregnant woman is exposed to a person with chickenpox, you do a varicella IgG in her, and if it is positive, it means she's immune. You just reassure the lady. If the rubella IgG is negative, then you have to follow her up for 4 weeks for the illness. And even if she does not develop an illness, you still have to investigate her because, as I said, rubella can be a subclinical infection. So you do a serum IgG and IgM rubella 6 weeks after exposure. Whereas if she gets an illness, you do an IgM immediately, an IgM and IgG 2 weeks later. And if both are satisfied, that means you have a I positive IgM and a conversion from a negative IgG to a positive IgG, you confirm it as rubella, and you have to then offer her MTP if it is the first trimester. So in this patient, what you will do is you will do a rubella IgM in the child and the rubella IgG in the mother. And if the rubella IgM in the child is negative or the rubella IgG in the mother is positive, you need not do anything. And this also brings us to this important point that all women who come for preconceptional counseling should undergo rubella IgG testing and a varicella IgG testing. And if these are negative, she should be given the MMR and the chickenpox vaccination. In order to eradicate the problem of congenital rubella, our government embarked on the MR campaign in 2018 to 19, whereas all children below the age of 15 years in this country were given the MR vaccine. And hopefully the problem of congenital rubella should reduce with time. And finally, the last case. This is a case of a multi-gravida who had been detected with unexplained IUGR in the 3rd trimester at 32 weeks. And again, a TORCH screen was set. Now this screen came back with a positive herpes, IgG and IgM report. Now this mother on questioning did not have any history of genital herpes. So what should be done? And I mean, as a reflex, some people will put these ladies on acyclovir. But it is important to understand about herpes before we take any such wrong decision. So most often the affection of the baby occurs when a mother gets herpes around the time of delivery. And genital herpes can occur both due to HSV1 and HSV2. And no shedding is asymptomatic. Now, risk of transmission of herpes to the baby occurs with primary herpes. So if a mother gets primary HSV genital herpes at the time of delivery, the rate of transmission is as high as 41%. Whereas if it is non-primary or recurrent herpes, the risk of transmission is very low. So the only benefit of doing these HSV antibodies, that is either HSV1 or HSV2, is to classify the episodes of herpes as primary or recurrent. Because if a mother has genital herpes and her HSV antibodies IgG is positive, it means this is not a primary infection and there is very low risk of transmission to the baby. But remember that neonatal herpes can be a very devastating disease with a very high mortality. And these babies come with skin lesions, vesicular lesions, and also encephalitis. And if you make a diagnosis of HSV encephalitis in a newborn baby, apart from treating them with IV acyclovir for 21 days, you have to give them oral acyclovir for up to 1 year to prevent recurrences of HSV. So how do you manage herpes simplex infection in pregnancy? So if she has a primary episode, which is either in the 1st or 2nd trimester or in the early 3rd trimester, means a woman who has genital eruptions and she doesn't give a history of herpes earlier, you will treat with acyclovir and you will consider giving a suppressive dose of acyclovir from 36 weeks of pregnancy and allow a normal delivery with no special care. On the other hand, the most dangerous situation is if she gets the primary episode less than 6 weeks from delivery or around the time of labor. In this situation, you will send a viral PCR and do type-specific HSV antibodies. For example, if you send a PCR and it detects HSV1, whereas the type-specific antibodies are HSV2, it means it's still primary herpes and not recurrent herpes. That is why you have to do type-specific antibodies here. So if the type-specific antibodies are absent or not available, you will counsel this mother for an elective C-section. And if these, if the woman undergoes a vaginal delivery, then you will monitor the baby. You can send swabs from the baby's mucosa and skin and start prophylactic acyclovir if the results come back. Whereas if you have type-specific antibodies present, then again, you just allow vaginal therapy with no special precautions. For recurrent genital herpes, there is no problem. You treat the episode and consider suppressive acyclovir. So therefore, as you can see from the algorithm, the usefulness of HSV antibodies is minimal, and that is to classify an episode as primary or recurrent. That this is a serology which should not be done. So in this lady, basically she had HSV IgG positive. She had no eruptions or lesions, and you have to do nothing with this. So finally, I would like to summarize that torch infections cause morbidity in the fetus and the newborn. These are challenging to diagnose and treat. There are significant implications of overdiagnosis as well as underdiagnosis. And therefore, to avoid opening the Pandora's box and avoid a headache, you must send these investigations and torch serology only if indicated. And what you should focus on instead is antenatal rubella and chickenpox vaccination and screening for hepatitis B, syphilis, and HIV in pregnant women. Thank you. With that, I will stop sharing my screen and take questions if there are any. Thank you so much.
Thank you, Dr. Tanu. Can she hear me? Yeah, Dr. Tanu, can you hear me?
Yes, can you hear me? I'm here. Hello.
With that, let me share my screen.
Yes. I hope you can hear me.
Yeah, Dr. Tanu, we can hear you. I think you also can hear us.
Yes, very nicely.
I think you, thank you very much for your crisp lecture. And you describe very nicely all the
torch infections basically refers to infections in pregnant women and newborns.
I think they have replayed it here.
Yeah. So you nicely describe all the 4 important infections that is a torch includes, though torch includes other infections also, but you nicely describe and you gave the important points to how to manage when the patient, I mean, case-wise, you explain everything. There should not be any doubt when if it is a IgG positive, IgM positive, because of the lack of the awareness. I think whenever there is a IgG positive and they doctors, they advise them, you please get the pregnancy terminated. That is not right. You nicely describe when the abortion is indicated and when it is not indicated. So thank you very much. I think there is any question?
Tanu, I'm Arvind in India. We know each other quite well. I have to ask you, in a mother who has never been immunized for MMR as a baby, which we will see often in this country, should we not do a rubella IgG in the first trimester or prior to conception, so that she can get the MMR vaccine and get at least one risk factor out of getting congenital rubella?
So I did mention that as a part of preconceptual counseling, one must either do a MMR, rubella IgG, or even just give the MR vaccine, because there is no harm in giving it if you can't afford doing the test. But once she's pregnant, then we can't do the test, because even if she's rubella IgG negative, we can't give her the vaccine. Then the only thing which we can do is to tell her not to avoid exposure to children with exanthematous illnesses.
Yeah.
But
Excuse me, Dr. Tanu, if she's negative during pregnancy, definitely, but you have to warn her. You might get the infection. Then there are chances to the infection to the baby and anomalies in the baby. Yeah, if she's coming before pregnancy for the counseling, then definitely we have to do the rubella IgG. That is a part of the routine prenatal test. We always do rubella IgG and VDRL, that always do. If it is a negative, we advise the vaccine if she should take, and suppose, and we warn her not to get pregnant within 1 month. At least if she suppose gets pregnant, she nicely described, if she gets pregnant, that is not an indication for the termination of the pregnancy. There is no harm. She can continue because the vaccine would not harm the baby.
I have a follow-up question on this. Rubella virus, which is part of the attenuated virus of the MMR vaccine, has never been known to produce congenital rubella in the newborn. So even if the mother is rubella negative in the first trimester itself, should we not give this mother an MMR vaccine?
Yeah, because this is live attenuated.
Yeah, but
so
it's
we try to avoid, especially in the first trimester.
Okay, but it's never been known that MMR attenuated rubella will ever give rise to congenital rubella.
I think
That's
this
been
is a research
documented.
question.
This is an important question, but if you know that she is pregnant, then as per the indications on the label and legalities, you can't give it to her. But I think you have made an important point, but as of now, I don't think we can do it. If we know that she's pregnant, we can't give her the MMR vaccine or the chickenpox vaccine or any other live attenuated vaccine.
Chickenpox, yes. Rubella, I'm questioning basically.
Yes, yes. That's an important point though.
So that is a research question. I think we have to do the research and we. Yeah.
Ma'am, thank you for a very clear talk. I just wanted to ask, most of the time CMV and herpes serology comes positive because of cross reactivity. They belong to the same group of virus, herpes viridae. So what I have seen is when we interpret CMV, IgG, IgM, the HSV also has to be considered accordingly. Most of the time, because the same family, the antibodies cross react, and most of the time we get them as positive in both the cases. So the interpretation has to be taken with all four together most of the time. Your point on that?
Yeah, I don't think there is so much of cross reactivity between both CMV and HSV. So if your HSV is positive, it can be due to exposure to HSV and not CMV. And of course, if you're asking for an HSV serology, then you have to ask for both HSV1 and HSV2. And yes, you do, but you do see so many instances where you have a CMV IgG which is positive and an HSV IgG which is negative. So because I've yet to see a person who is CMV IgG negative, but you see lots of patients who are HSV IgG negative. So when you are interpreting the results of HSV in a patient who has genital herpes, if her HSV IgG is positive, you can assume that it is due to HSV exposure and not CMV exposure.
Yeah, Dr. Tanu is absolutely right.
Thank you.
Yeah. And we, without any indication, we don't advise these investigations until if there is an indication. And if it is IgG positive, then there is no issue. Patient is immune. No, never. Even the panel also, if it is indicated, then only we advise.
Okay, thank you. Thank you, ma'am, for this enlightening session on torch infections. Thank you, Dr. Tanu.
Thank you so much. Thanks, Neha, for inviting me and also to give to attend this conference virtually. Thank you so much.
So moving to the last topic of this afternoon, HIV diagnostics. The speaker for this is Dr. I.D. Khan. He is a microbiologist at the base hospital. And I request Dr. Sangeeta Nag to chair the session. She's a senior physician with special interest in HIV medicine in Delhi.
So I invite Dr. Khan for his presentation on this important topic, how to diagnose HIV, what are the lab tests. So over to Dr. Khan.
Thank you, organizers and chair. So I understand that I am standing between lunch and all of you. So in the next few minutes, I would like to just briefly give a overview of how HIV diagnostics have been and have evolved, if at all. So I'll be covering my talk in the following heads, and I have nothing to declare. So with the tenets of consent, confidentiality, and counseling in HIV, there is a mandatory testing in which there is a HIV screening for donors. And there is an unlinked anonymous testing, which is meant for HIV prevalence. There is also a voluntary confidential testing for diagnosis in asymptomatic or symptomatics. For HIV prognostics, we can have, and to ascertain the virological and immunological failure, there we can do a test like CD4 count. And for antiretroviral drug resistance, we can do and we can assess the treatment failure. In addition, we can screen for opportunistic infections as well as HIV defining or associated tumors. So there are various targets here, and it is kind of an exhaustive list. So the targets can be, the most important target still is the IgG antibody, in which is targeted by either a 3rd generation ELISA, or now we have moved to the 4th generation ELISA as well. And we can have an immune complex dissociated ELISA. We also have rapid tests like ICT, HIV spot, and HIV tridot, which have been there for the past few years, more than a decade. We also have simple tests like latex agglutination or gelatin agglutination or passive heme agglutination or a Kuhn test, which have not been under much of use these days. Western blot is also falling out of favor, and immunofluorescent assay is also kind of difficult to conduct. So basically, then another target is the antigen, in which P24 antigen has come in the past decade, and this has revolutionized the window period with the advent of 4th generation ELISA, and an ultra sensitive P24 assay is also there. So this is now being utilized for donor screening, newborn diagnosis, and prognosis as well. Other targets can be RNA, which is targeted by RT-PCR, and the better way is to do a quantitative RNA or viral load for prognosis. We also have a proviral DNA testing. This is kind of better, right? And this is also targeted by PCR or in situ hybridization. Now, this is important for testing in children. However, before the age of 48 hours, the sensitivity of this HIV proviral DNA is only about 40%, which improves to 99% at 6 weeks. So there are novel approaches which are in lieu of the HIV viral load, such as the reverse transcriptase activity, which correlates to viral load. It is slightly simpler. It's an ELISA-based antibody approach, and the sensitivity is more than 300 copies per ml. So with less than that, it won't be able to pick. Secondly, we also have a P24 antigen boosted ELISA. This also correlates to viral load, and this has a combination of ELISA as well as a tyramide signal amplification. Sensitivity is between 200 to 400 copies per ml. Genotyping can also ascertain the type, group, and clade of HIV, also CCR5 receptor and co-receptor tropism. Viral culture is also not being practiced for HIV diagnostics. And earlier, HLA B5701 was done when abacavir was a part of the treatment. Nowadays, it is generally not done. If you have to assess the immune defects, to assess the adaptive immune system, we have the CD4 and CD8 count, and we have a CD4 percentage instead of an absolute count for children under 5 years of age. This is because in this age group, the absolute CD4 normal count is also higher. So that may lead to a false reading. So we assess a CD4 percentage in this age. Excuse me. We can also assess a reversal of the CD4 and CD8 ratio. We can look for beta-2 macroglobulin, HLA-DR, CD38, Ki67, caspase-3, CD28, CD57. It's a long list. Many more tests are also there, but generally they are not done in a normal patient. For innate immune system, we have CD38, CD86, and CD69. All of these can be targeted by flow cytometry. For drug resistance, now HIV is a highly mutable virus. So there is one mutation per replication cycle. There's a very high recombination rate, and there is periodic reactivation of latent HIV as well. So drug resistance is by and large because of selection pressure, or it may come from one patient to the other patient in case there is a transmission of a drug resistant mutant. But de novo, it does not exist. So it can be targeted by nucleic acid sequencing, wherein we can do the mutation study and we can see the resistance to HAART. There are some special HIV tests like lymphocyte transformation test to detect cell-mediated immunity, profile assay, and phenoscript assay. So the targets are some more here. We have got a lot of biomarkers like neopterin, ESR, IgG, IgA, IL-2 receptors, IL-6, HSCRP, WBCs, platelets. For coagulation markers, we have got D-dimers, protein C, protein S, thrombin, and antithrombin. For microbial translocation, we have got lipopolysaccharide, anti-lipopolysaccharide core antibody, microbial DNA, 16S DNA. I'm just reading out the list. It's a huge list. Monocyte activation, soluble CD14, T cell activation, soluble CD27 and CD40 ligand, and intestinal epithelial injury, intestinal fatty acid binding protein. So that was about the target. So you've got so many things to do. HIV diagnostics has remained a complex thing for many years now in the past 4 decades. However, some strategies have been there which have been evolving. And now when we had the classical strategies of screening tests, which were based on ELISA, rapid and simple, now we have moved on to the 4th generation ELISA, which has brought down the window period to about 12 days or so. Rapid tests are still being used and simple tests are generally not in use much. We also have supplemental tests like Western blot, line immunoassay, immunofluorescence assay, and recombinant immunoprecipitation assay, all of which are slightly cumbersome and not much in use. And confirmatory tests like HIV RNA, which also gives a viral load, or HIV proviral DNA and P24 antigen are very much in use now. There is another strategy here, which is known as the recent infection testing algorithm or serological testing algorithm for recent HIV seroconversion. Now, this is a population-based strategy. This is not meant for individual patients. And here, the test sensitivity is reduced and it is mixed up with another test of a higher sensitivity. So we have got targets which are having both higher and lower sensitivity. And this basically is able to detect the recent HIV seroconversion. Some of the tests here are detuned ELISA, BED capture ELISA, IgG avidity ELISA, ID3 V3 immunoassay, and anti-P24 IG3 isotype. In addition to these strategies, now the UNAIDS 1990 strategy, which was meant to achieve 90% diagnosis, 90% people under treatment, and 90% people who are virally suppressed. In the year 2016, South Africa, which has got the highest prevalence of HIV worldwide, started a universal testing strategy since 2016 and has been able to penetrate more than 90% of the population in its goal. In the sub-Saharan Africa, this 90% testing availability is also has been achieved in a large number of countries. So this was one strategy. There is one more strategy, which is known as HIV self-testing strategy, which was also launched a few years back just before COVID in Africa, and it has also been fairly in vogue. In India, as of now, because the prevalence is less, it's just 0.2%. Self-testing strategy does not mean much, but the system is available, the infrastructure is available. Only thing we need to do is some public health campaign for self-testing strategy. It is a very, very simple thing to do, and it is also quite a possibility. But I must say that over the past 40 years of HIV, in all these 40 years, the social determinants of HIV have improved quite a lot. We have got a U is equal to U strategy that is coming up. So many, and if you see the number of publications in HIV, about 80 to 90% of publications are in the social domain. But if we see the actual technical domain in which we can work on the window period, because window period, when we miss on the HIV test, we still get a lot of infections, but we have not been able to develop much on reducing the window period in these years. So we still have these strategies where with the NACO strategies has this, the strategy 1, 2A, 2B and 3 strategy in India, which in other countries which have got more than 10% prevalence have got slightly different strategy. Now, if we do a diagnosis with these three, the strategy 3, which is meant for all the antenatal patients, also for all the pre-surgical patients, and also for the voluntary confidential counseling and testing center patients. So what happens is that we do 3 tests, which is in itself cumbersome. And if there is any doubt, we have to do a confirmatory test or a supplemental test, which is also cumbersome. This increases the turnaround time. In addition, there is no gain in the window period whatsoever. So the window period at best with the nucleic acid amplification test is about 7 to 10 days, which is again not very good, because we should be having in these 40 years, we should be having something which is like single test, which is confirmatory and which can be there which can detect in just 2 days, which we don't have as of now. So the current algorithm of this screening and confirmation increases the turnaround time, and the universal screening program is also quite the same. It has not changed. In the Western world, there has been some changes. Now they have started an early HIV RNA testing, which has reduced the turnaround time, and also it has averted the misdiagnosis in about 8 to 30% patients in a lot of studies. Universal screening has been also instituted in all people who are 15 to 65 years of age, and all high-risk people who are even any age. So this is one change which has come. And in our center, in the past 6 years or so, we have also adopted this early RNA viral load testing, And we have this CBNAT or Gene Expert platform. So what we have been trying to do, again, this is not a published study, but we have been trying to do is that the day when we get the sample, we try to do all the 3 screening tests, and immediately, because we don't have Western blot is also cumbersome. So same day we do a HIV viral load testing from the same sample. Now this has got 3 clear benefits. One is the same day confirmation. Second is the early initiation of HAART, because in the evening by 2 o'clock these tests are done, and it is possible to start HAART immediately if the patient profile is like that. And also it can reinforce 2-tier infection control at all levels. So this is something which we have tried. But even with all this, whatever is there, we have got a lot of, not us, I mean to say there are a lot of false positives in the entire diagnostic paradigm. So these false positives, there's a huge list of diseases, but the chances of false positives are not much more. What is more important is false negatives, and the false negatives will be 0.0012 to 0.3%. Now this can be because of window period. I'm just reiterating the things, but it is important. And for this, we need to do a repeat test. Now, unfortunately, with the screening strategy, when we do a first test and it comes negative, immediately it gets labeled as negative. Now, this is something which needs to be changed, because the first test coming negative is not something which is sacrosanct. So we need to do something for this first negative test. Now, this is something where we miss a lot of HIV positive patients. And when we have to think of the 1990 strategy, we will be very, very far off with this kind of a testing in which when the first test is negative, it is labeled as negative. But unfortunately, there are no guidelines and we cannot do much about it. Then this false negative can also occur when there is a seroreversion in late stage, or because of agammaglobulinemia, or because of immunosuppressive therapy, or B cell dysfunction, or malignancies, or whenever there's a HIV1 group O or N instead of M, or where there is a HIV2 there, though it is rare, right? So other challenges and opportunities that we face is that there are a lot of opportunities where the screening is missed. Now this can be changed when there is a high index of suspicion and frequent screening. So because we have this, the tenets which have confidentiality, counseling, and then consent, all these things, they're actually a deterrent to more testing. We also have delayed treatment like early viral load testing. We have treatment failure, and the diagnosis in children is also kind of difficult. I'll take 2 more minutes because there's something which I want to highlight here. So in this, now there has been a kind of success in HIV therapeutics, which is changing the HIV paradigm. Now this is not something which is recommended. It has just come on 15th of Feb 2022 in the conference on retroviruses and opportunistic infections. One of the first dual haplocord transplant was found to be successful in a 64-year-old female who was having leukemia. So this is known as a US New York patient to protect the identity, and she was given a dual haplocord transplant. How this worked was, initially she was given a fetal cord stem cell transplant of a smaller complement, and the next day she was given a larger complement of adult stem cell transplant. Now this was having a CCR5 delta 32 mutation, which is known to be HIV resistant. So it is difficult to find donors because the prevalence is less than 1%. And the dual haplocord was also tried in 2 more patients, and all of them have found to have very low viral loads. This procedure is something which is upcoming, but it is risky because we cannot do a stem cell transplant in all normal patients, right? And one more patient, 2013, it was tried, but that patient died of cancer. If you see the history, this CCR5 targeted therapy with bone marrow transplant alone has been found to be successful in the Berlin patient, London patient, Dusseldorf patient, and 6 more patients, and all of them have been found to have low viral loads. CRISPR-Cas deletion was tried in 2018 in China baby, was also found to be successful. And one more thing which is important here is the natural elite controllers. Like we have the Esperanza patient, right, and the California patient. Both of them have got sterilizing cure or functional cure. And no intact HIV genome has been found in more than 3 billion cells in the Esperanza patient. This lady is age 30 or 32, and she has got 2 children. She has got living a normal life. So what we can do here in HIV diagnostics to explore these strategies? So the treatment strategies are poke and clear, or kick and kill, or it can be block and lock or reduce and control. I'm not explaining this because of shortage of time. So what we can do as a future of HIV diagnostics is that we can do a population donor screening. We can do whole genome mapping or screen for the CCR5 delta 32 mutation to have a bank of such patients. This kind of bank is available in Western countries, maybe not so much in India, but maybe it is just upcoming, or we can have newer testing strategies. In the recipient testing, where we give this bone marrow transplant, we can look for the engraftment if it is early or it is delayed, or we can look for immune cell screening or HIV antibodies, or experimental transfection can also be tried. It was tried in this HIV, in this New York patient, and it was found to be successful. we also need to have a theranostics approach now. It has been, the theranostics has already been there in radiotherapy and nuclear medicine, but now we need to think about theranostics in HIV as well. Because the prevalence has reduced, the incidence has reduced, we have got new strategies, and with this, remission versus cure is the debate now. And if we adopt new medtech like artificial intelligence, machine learning, and leapfrogging of new technology, we can reduce the cost, we can improve the penetration, we can have better HIV healthcare accessibility. So with this, I conclude that high suspicion required is for screening. Universally counseled screening in high-risk population is another important thing. Early deployment of HIV RNA or DNA, especially by gene expert, because it just take 2 hours, can reduce the turnaround time. It can have multiple benefits. We can start the treatment early as well. We can also have to focus on leading edge HIV therapeutics, and leapfrogging is another important thing. And we need to have multidisciplinary research. Right, with this I finish. Sorry for the delay between the lunch and you.
Hello. This was an excellent talk. I think the very crisp presentation. I think Dr. Ruby Bansal has a question.
Thank you, ma'am.
Reject HIV-1 and HIV-2, and we should not forget about the HIV-2.
Definitely, ma'am.
As only the CAR test is giving you the answer of HIV-1 and HIV-2. And I think there is a role of Western blot if we want to diagnose the HIV-2. So
yes,
just it was a...
Another thing, ma'am, we can also target the molecular approaches. We can look for HIV-2 RNA and HIV-2 DNA.
Yes,
that is
yes. HIV-2 RNA is also available, and you can do the viral load. So, but basically because India definitely not having that much of the HIV-2, but still we have many cases, right, of the HIV-2. So we should not miss HIV-2 in our diagnostics.
Definitely.
Yes, we have. We do have. Metropolis is doing the HIV-2 viral load, and it is. I mean, not all the labs are doing, but Metropolis is doing, and we can see the viral load. I have a couple of the patients who have the HIV-2, but definitely it's a slow progressing disease, so you don't find the viral load maybe the many years. So, but still, the test and treat strategy is for the HIV-2 also applicable.
Yes, please. Yes.
One thing I was very good thing you are doing those antibody plus NAT you are both doing that reduces a lot of window period, and because we some of our even staff got HIV transfusion shirt, we are not allowed to do those things like NAPO guidelines. They don't allow us. Like if we are doing antibody based test, they just say that now we can do just for therapy monitoring or for diagnosis purposes. So one thing that is quite good, but just one thing I want to correct. Now we have 95 strategy, yes. Not in 2021 because of this COVID pandemic. They have just accelerated it as 95,
yes.
95. And the concept of self-testing, we have very serious issues with this because the post-test counseling, we can't go for it in self-testing. And another thing was that if a person hides out, the chain of transmission in the society can't be break out. And given the fact that 75% of our cases in India are symptomatic, when they are diagnosed in life, they have less than 350 count in 75% cases. So self-testing is not recommended here. Yes, 3 things.
So I agree with all of your observations, and I purposefully didn't mention the 95 strategy because it's yet to be deployed. So we are very far off from the 90% strategy.
Ministry of Health and Family, they have detailed guideline now in the site.
Yes, the guidelines are there.
Any other question? So I think we can wind up the this session. But before we go for dinner or lunch, I would like to share one small little observation of mine that I recently was searching through the WHO guidelines in clinical testing, and they have said, they over there, they say that there is a pre-test counseling. They sent out a clear message to the patient that if you are already on ART, please don't go for a test. It can be falsely negative, which I think we people as clinicians, we must know this, that many of our patients, when they are on ART, these tests can be negative. So, and many patients, then they feel very, sometimes I will say even aggressive also, can become aggressive, that all of a sudden their test has become negative and I was on a false treatment. So I was going through this WHO guidelines 2019, and there was this information was there on page number 72.
Basically, because after the ART, once you are treating, definitely you have seen the multiple times the viral load not detected. So that is very important to counsel every time the patient, once your viral load not detected, does not mean you are HIV negative. And the reason is very simple, because the patients are doing a lot of window shopping. So they are going through from the one doctor to another. They feel good at least, even the lab person, they are also the guiding force. They will tell, आपका तो HIV है ही नहीं, तो आप क्यों ट्रीटमेंट ले रहे हो? So this is even a simple, just a statement can give them the false sense of security of this thing that they are HIV negative and they were falsely treating or something else. So we should be very careful about this every time to counsel the patient. I used to do is your HIV test, HIV viral load is negative, does not mean you are negative. It is negative because it is not being detected. The viral copies are less, the machine is not detecting, but you are still positive. So that is the one that's the difference.
So thank you, Dr. Khan. I think you must.
So we had a good academic treat today. Regarding the poster session that we had yesterday, I would like to thank all the participants for a very enthusiastic participation, even after it was a very short notice for them. So regarding the prizes, Dr. Nisha Rathore won the first prize and Dr. Renu Kumari won the second prize. And we'll be mailing you the certificates to, as soon as possible. So congratulations and thank you. I would request Dr. Neha and Dr. Atul to please give the concluding remarks.
Thank you all. I think it was a great event because of all of you being here. And it was a great initiative by Dr. Neha and all of us that we could get this Delhi chapter started. And I hope with all your support, we take it further and have more such meetings. Thanks a lot. And there have been a lot of queries regarding the SIDS membership. So probably all of you can join in, whosoever are interested. It's available online. You can go onto the site for the SIDS membership on the SIDS website and can become members. And there is, as Dr. Subramaniam has already told that about the national conference, so all of those who are interested in Kolkata in July can also register. Anything you want to add? Okay, thank you. Please join us for lunch. The lunch is at the same place where the tea was, so you can join in. Thank you so much. Thank you.